Raising People Up is an employment initiative aimed at providing employment opportunities to people who have traditionally had the doors shut on them in the past. We started this program because we work in hospitality and our job is to take care of people. Every day we are going the extra mile for our guests, so it only made sense that we should go the extra mile for our employees as well. This means employing people with criminal histories, people who are in recovery from substance use disorder, people with profound disabilities, as well as refugees who are starting their lives here in Maine. It's important for people to know that we are not lowering standards, we are just widening access.
Not everybody is willing to give us a second chance. And to have Nonantum come and take us in was amazing. I'm forever grateful.
Education and stable employment make a tremendous difference in reducing recidivism. We try to create a seamless experience by providing employment to people who are currently incarcerated so that when their sentence is over, they have a place to come.
My very first day at Nonantum was exciting / had all the feelings, anxiety, but I actually finally saw hope. I actually felt like I was going to belong somewhere.
As a person who's in long-term recovery myself, we have success stories. And if we allow folks to come into our communities and become very successful, we'll make recovery very visible and will help attract others who want the same thing.
My situation before coming here was I was in prison. I had a 4-year bid. I got out to a sober house. I didn't really have a lot, and I actually have stability now. And I actually have a light at the end of the tunnel, I guess you would say.
We use a wraparound support model, which means understanding that our employees come to us with a full human set of needs, and a job is not going to solve all of their problems. We help them do things like get a driver's license, navigate childcare, figure out how they're getting to and from work, and in some cases, we house employees. We have a van here at the Nonantum that travels to the correctional facility in Windham, as well as to some residences in Sanford, and takes about 13 people to and from work every day.
Not having the support from Nonantum would be very hazardous, I believe. Stable housing and help has completely changed my outlook. It's so hard out there, especially coming out of prison. They don't give you much to work with. You don't have a bank account, didn't have a license. There's a lot of things, that you really have to start building for. You actually got adulting, which can be a struggle, as we know.
The atmosphere at the resort has completely changed since our program had started. We are a more caring, compassionate, empathetic group of people. We have the ability to communicate with each other, but from a place where you're seeing it from the other person's point of view. And we just didn't communicate on that level prior to this program starting.
The best part of being a team at Nonantum is that we're one big family. Everybody respects each other, nobody treats anybody differently, and everybody is willing to lend a hand whenever needed.
What I would say to another general manager that doesn't feel they have the capacity to manage this extra level is, how can you not? Having gone through this program and working with all of these individuals, it is the most fulfilling part of my job. Does it take extra time? Yes. Does it take extra energy? Yes. But I can't imagine the Nonantum without Raising People Up.
I understand that starting a program like this can seem really difficult, but barriers are not a reason not to try. We asked ourselves, how can we make this work, rather than why can't it work?
The Nonantum is a leader in reducing the barriers for those individuals who want to pursue a career and live their best lives. We have a choice to make. How do we want folks who are just as involved to return back into our communities? Do we want them successful? Do we want them to have jobs? Do we want them to find housing? Or do we want to turn them back and bring them back into the system?
I was sitting across from a business who was hesitant to hire somebody with a record. I would tell them that they could change somebody's life. Everybody needs a second chance. That second chance could make or break somebody.
This is a nice thing to do. It's the right thing to do. But this isn't a talent attraction model that successfully puts people into jobs. And you know what? At the end of the day, this is generational change.
Let's give a nice hand to the non-anthem. So good morning again. It's just fantastic to see you all here. We had, as of last night, Lorena tells me we had about 1,130 people register, and virtually, while there is a virtual option, almost all of you are here, and we are very grateful. I'm Gordon Smith, the State's Director of Opioid Response, and we have our own personal cheering section down here, led by my sister, Edie, who just retired from Senator King's office. Building hope, honoring progress, inspiring change. That's what we're here today about. Charlie Hewitt's beautiful, hopeful sign down here in front of me, many of those hanging in your communities, is the perfect complement to our keynote speaker this morning. And I want to thank the Maine Development Foundation, who this is their personal copy of the hopeful sign. We have a fantastic day planned for you. My job is mainly to moderate, keep things on time, and I'm proud to say we are already running a couple minutes late. But we have a lot of time built in. We've got some nice breaks for you. We've got our lunch period. Of course, we'll see the governor later. We've had a couple people that aren't going to make it, I'm sorry to say, but for very compelling reasons. One of our breakout sessions, led by Song for Charlie Foundation, the co-presenter, Marsha, plane was canceled from Florida. We understand those things now, and it's inevitable. But Denise Mariano was presenting with her and is here, and did get her flight up from New Jersey. The Attorney General, he called me 2 days ago to say that because of the situation in Biddeford, he just was unable to come. And I told him you would all understand. He's doing his job, and that has to be his priority today. Before introducing Chief Sabatis, I just want to note that we have 40 Voices of Recovery today, that every session we have is going to open with a Voice of Recovery. Alan and Katie will be our first Voice of Recovery after a couple of our opening welcoming talks. And 40 voices is the most that we've had. But this was an idea that Leslie Clark had in 2019. Some of you, how many of you were at the Augusta Civic Center with us in 2019? See, that's a lot, that's impressive. Leslie had the idea that these programs, these summits, at that time it was just a conference, needed to be about people in recovery and people still struggling with substance use disorder, and that we should feature them. It should be about them. And it was so popular. Honestly, we recognized almost immediately that people don't remember what Sam Canonis said in June of 2019, but they remember the Voices of Recovery. They remember David and Shelley Yankowski, who will be back on the stage with me at 11 or so. And so every year now, for 8 years, we have asked people if they were interested in sharing their story. And we have way more stories, of course, than we have available sessions. But because we do have 38 sessions and 2 plenary sessions today, we were able to recruit successfully 40 Voices of Recovery. And this is about them, and it's about all of you and the work that you do in the community. So, as has been our tradition for 8 years, we're going to have a warm welcoming ceremony from our native populations. Chief Clarissa Sabatis, who is a healthcare provider, nurse, as I recall, and but also a musician, and also the chief of the Maliseet band in Holton, and we are so grateful for her to do an opening with us here this morning. Thank you, Chief Spatis.
Willie Zabawel, Nodali Wiz, Sagum Clarissa Sabatis, Willis Degoy Nilun, Nujiao, Miduk Sanagiak. Good morning, my name is Chief Clarissa Sabatis. I am Maliseet, and I am from the Holton Band of Maliseet Indians, and we reside along the Paduxikeg River, which is part of the greater St. John watershed. Today I'm just going to offer you a welcome song. Traditionally, when we gather and we welcome folks in, we offer songs if we're in our homelands. So, this is the Dawnland, home of Wabanaki, but more specifically, Penobscot territory. And I just wanted to offer a welcome song, but also thank everyone for all the wonderful work that you do. None of us are immune to this epidemic that's happening in this country. And, our tribal nations have been doing a lot of wonderful work in this space. I know I've seen some faces in the crowd from different tribes, and I'm so happy and so grateful for all of you, tribal, non-tribal. This is a wonderful video. I love that we have businesses that are willing to welcome people in and understand that everybody has a past. So thank you all, and thank you for the invitation to come and to provide a welcome song to start this off in a good way.
Thank you, Chief Sabatis. You've been an important part of this summit for a few years now, and before you, Lauren Stevens, and we are so appreciative of our relationship with Wabanaki. We're next going to hear from Jennifer Gunderman, who's the Director of Public Health and Community Services for the City of Bangor, who will provide a welcome to this beautiful city. Jen?
Good morning. Wow. Gordon gave me very clear instructions and guidance to prepare me for this welcome. But my goodness, he did not prepare me for this moment. Looking out at all of you is truly humbling. You are people who have dedicated your lives to helping others heal, recover, and find purpose. And I am completely awe-inspired in this very moment. So, on behalf of the city of Bangor, I welcome you to the Queen City of the East. In Dr. Brené Brown's latest book, Strong Ground, she explains that a key ingredient for successful and effective organizations, communities, and leaders is paradoxical thinking. It is the capacity to embrace and navigate the tension between opposing truths until a new idea or insight emerges. I believe that we are holding this tension between conflicting truths right now together in this room. There is the truth that the need for this gathering has roots that go way back to greedy drug companies and mis and disinformation that drove opioid prescribing practices. We are here because people are and have been in deep physical, emotional, and spiritual pain. We have tragically lost people that we love and that we miss every day. We come together in Bangor, where we have the highest fatal overdose rates in the state. We have an unprecedented HIV outbreak linked to injection drug use and homelessness. We have a divided community fueled by stigma that is evident at city meetings and on social media. These are very hard, real truths that leave us with feelings of exhaustion, grief, and sometimes doubt. However, the magic of paradoxical thinking is that the opposite is also equally true. There is the truth that this gathering represents innovation, resiliency, empathy, and dedication. Today, we will learn, be inspired, and lean on each other for support. We are here to discuss creative, evidence-based solutions, establish new partnerships, and maybe even most importantly, hang out with friends. We gather here in Bangor, where healthcare providers, first responders, social service agencies, recovery organizations, public health professionals, people with lived experience, and community members come together to build what I believe is one of Maine's strongest collaborative responses to challenges that many would consider insurmountable. These are real, wonderful, beautiful truths that leave us with feelings of connection, renewed energy, strength, and optimism. Paradoxical thinking allows for courage and vulnerability, compassion and boundaries, fear and joy to all exist at the exact same time. It reminds us that hope is not merely the absence of hardship, it is the decision to keep showing up in the midst of it. And you all continue to show up. If paradoxical teaching teaches us anything, it's that we don't have to choose between acknowledging our struggles and believing in our future. We can hold both. And when we do, we create the conditions for real, lasting change. So thank you. Thank you for bringing your expertise, your compassion, and your hope right here to Bangor. Together, let's continue to build a state where recovery is possible, people are valued, and no one has to face their pain alone. Welcome.
Thank you, Jen. And And thanks to the city of Bangor and the Cross Insurance Center have done a beautiful job in helping us today, bring all of you here. I'm going to introduce our next two presenters together, just to save a minute, maybe. These are two individuals who I get the pleasure of working with every day. In the way that the governor designed this position as director in the governor's office of policy innovation in the future, I have no staff. I have nobody that reports to me. The tremendous work that's being done is really being done by people in the departments, in the offices, and my job is to break down those silos and to make sure everybody's working in the same direction. And nobody helps me more in this regard than Director Squirrel, Sarah Squirrel, who directs our Office of Behavioral Health, and Dr. Terry Varr, who directs the Maine Center for Disease and Prevention. So we are so fortunate to have these two individuals in Maine leading those two offices within the Department of Human Services. And so I'm going to call them both up now, and Sarah's going to go first, and then we'll hear from Dr. Varr. And thank you so much for the work that you do, Sarah Squirrel.
Good morning. What a beautiful day to be here in Bangor, Maine. Thank you for the introduction, Gordon. My name is Sarah Squirrel. It is truly an honor to serve as the director of the Office of Behavioral Health and to welcome you all here to Governor Mills' 8th annual Opioid Response Summit. First, I do want to take a moment and thank all the people today who made this wonderful event possible. I'll name a few names and then we can give them a round of applause. Catherine Coutu, Richard Frund, Stacy Chandler, Karina O'Leary, Kristen King, Rob Porter, Gabby O'Neill. I'd like to thank the team at ADAPT, especially Lorena Liberty, as well as Elizabeth Fortier from the Recovery Council. Please join me in giving them a round of applause. And we find ourselves gathered here today 7.5 years after Governor Mills was sworn into office. And if we had asked ourselves in early January 2019, where would we be in 7 years? Would we have dared to envision the landscape of treatment, reduction, harm reduction, and prevention that we now have in Maine? I want to thank Governor Mills for her leadership, for bringing us all here together. She has brought the full force of her vision and commitment to our opioid response. And under her leadership, there was a 46% reduction in the number of fatal overdoses between the peak in 2022 and 2025. I also want to thank my fellow leaders at the Department of Health and Human Services and our Commissioner, Sarah Gagne-Holmes, who is here today. For anyone who knows Sarah knows that she leads with integrity and compassion. I also want to express my deep thanks and appreciation to Gordon Smith, our Opioid Response Director. He's been the compassionate maestro of our orchestra, patiently guiding us and unifying us. And he has brought vision and a passion to this work that we will always remember. So the theme of this conference is building hope, honoring progress, and inspiring change. And one thing I've learned is that there is no progress without change. And when those of you in this room took stock of the devastation and the loss that the opioid epidemic brought to our communities, you did not hesitate to bring the full force of your voices for change, your conviction, and your compassion to bear. And for that, I thank you. And that is why we stand here today, having accomplished so much together. We've expanded recovery community centers across the state. Over 95,000 individuals last year attended groups. We've expanded our continuum of recovery coach training. Over 1,000 individuals last year alone received training. We've expanded our network of recovery residences. We continue to support our options liaisons who made over 4,500 community contacts last year. And we've expanded access to medication for opioid use disorder. We've expanded the quarterly census at our opioid treatment programs across the state by 66% since 2021, and we've launched our first mobile methadone unit here in Maine. We also established a treatment and recovery court in Aroostook County that officially began operations on July 9th, and we now have a network of 14 treatment and recovery courts across the state of Maine. We also recognize and remain focused on the co-occurring nature of mental health and substance use. And we all recognize that every aspect of our behavioral health system has to be welcoming and co-occurring capable. Next year, we will establish 2 new crisis receiving centers in Androscoggin and Penobscot counties based on the success of the Cumberland County Crisis Receiving Center, where they provided behavioral assessments to over 5,100 individuals, and 56% of those assessed met criteria for substance use disorder. We've joined other states and tribes across the country in implementing the 988 hotline, a new front door for any individual experiencing a mental health or substance use crisis. Over the last year, we answered over 150,000 phone calls into 988. And on July 1, we launched a new model of mobile crisis service delivery here in Maine that includes a peer support component that is aligned with best practice. I also want to talk about hope. Hope is tangible and intangible. It's the feeling in your gut when you've taken a tough stand, but you know it's the right thing to do. It's the heaviness in your heart when you mourn the loss of your loved one, but somehow the powerful voices of recovery lift you up and keep you going. Hope is leadership, and it's a skill we need to hone. Hope is the leadership of Katie Sell and Elsie Flemings, who work for Healthy Acadia and provide leadership at Safe Haven Recovery Residence for Women and Children in Washington County, where women can stay while they work through their recovery with their children at their sides. Hope is the compassion of Nikki Merrill, who currently supports our statewide recovery-friendly workforce initiative. Nikki spoke with me about how the initiative is truly breaking down stigma. She said, now employers know what to do. They see people, and they can help them in their recovery. Hope is the passion of Nicole LeMay, who is the peer recovery navigator for MAR and the executive director for Youth-Led Justice. Her Youth-Led Justice work, she supports youth who have been excluded from their communities, providing them with mentorship. And if you're looking for Nicole, you can find her in a public park in Lewiston, trading popsicles for conversations with young people. When I asked Nicole what gives her hope about the future, she said, what gives me hope is that we can thrive in the uncomfortable. You have to be uncomfortable to adapt and to change to help people, to find more compassion. And we must find compassion and we must find connection. All of our work needs to follow the arc of human connection across lifespan, the invisible strings of humanity that tie us together from our youngest Mainers and family to our older Mainers and whole community. And we know that we are standing on the balcony of a moment in time that is fraught with uncertainty. We are navigating federal policies that challenge our longstanding values, that perpetuate stigma and challenge years of research and evidence. But despite these headwinds, we persevere, we don't acquiesce, we resist. The state of Maine has joined multi-state litigation against every federal policy funding changes that would negatively impact our substance use, mental health, recovery, and housing programs. I would invite us all to lean in today to the theme of honoring progress. It can be so easy to focus only on problems, but that can create an exhausting treadmill and barrier to innovation. So let's take today to magnify what we've accomplished together, to look at the root cause of our success, and to let that be a catalyst and motivation for us all to keep going, to take care of one another, to promote and support recovery, with love, acceptance, and most of all, hope. Thank you so much for being here today. And now it's my pleasure to welcome to the podium Dr. Terry Va.
I know Dr. Vi just flew in late last night, probably drove up early this morning after taking care of her two little ones, so I am so appreciative.
Good morning. So Gordon, I'm going to apologize. I swear I'll try to stick to the 5 minutes you gave me. Thank you so much, Director Squirrel, for the introduction, for the wonderful words. Good morning, everyone, and welcome to Governor Mills' 8th Annual Opioid Response Summit. I'm Dr. Terry Va, the Director for the Maine CDC, and it is an honor to welcome you all here today. Community members, partners, advocates, leaders, and I'm grateful to everything that you guys do. To our leadership from Governor Mills, to our commissioner, to Gordon leading this work, and to everyone here, I know the collective action that was required to do this. All the commitment in saving lives and strengthening our state. We gather each year to recognize the vital work happening across the state of Maine, preventing opioid misuse, supporting recovery, and providing life-saving services that meet people where they are, when they need it, with compassion and care. Now, this is a collective lesson over the last 8 years in endurance, tenacity, resilience, and focus. Together, we have built one of the strongest, most coordinated responses in the nation, as evidenced by the stats that Director Squirrel has provided. And we are seeing those real impacts, and I'll provide more numbers. For example, as Director Squirrel mentioned, drug overdose fatalities in Maine fell to 390 deaths in 2025, a 20% decline since 2024, and the lowest since 2019, since the inception of this convening. Syringe service programs have doubled enrollment over the past decade, now reaching nearly 12,000 people statewide. And through this, yeah, exactly, woo indeed. And through this work, on the ground work, you know what? Infectious disease screenings have increased consecutively over 6 years. More than 648,000 doses of naloxone have been distributed since 2019, contributing to over 12,600 potentially fatal overdose reversals. Those are lives. And very well worth celebrating. SSPs are functioning as true community hubs, making nearly 52,000 referrals last year alone to medical care, behavioral and mental health support, and pathways to recovery. Those are numbers to celebrate. Here's an example of how one of our organizations that hosts an SSP are investing in expanding and adapting their services to fill gaps needed by the community and to meet the needs of the communities they serve. For instance, one of our SSPs invested in expanding beyond just SSP services and hired a part-time physician who provides primary care to its members and to surrounding community members. These outcomes reflect thousands of lives touched and saved, and they are possible because people sitting in this room today, like you, show up. So words of gratitude alone don't feel sufficient. What you offer is something much deeper. It's love for a community. We also know that progress doesn't mean that our work is finished, and caring for people through strengthening prevention and addressing conditions that lead to substance use, it takes time. So we continue to build healthier communities for today and tomorrow. But what does that tomorrow look like? If you want to see the future, and we want to see what that tomorrow looks like, all you have to do is look at the now. Now look at how our kids are doing, the well-being of our youth. Tell us what our future could look like, the health of our communities, the challenges and opportunities the next generation may face. And their story right now gives me a lot of hope, so I'm going to give you more positive numbers. And since this summit first convened, Maine's young people are reporting fewer risky behaviors. So between 2019 and 2025, alcohol use dropped from 22% to 16%. Cannabis use dropped from 22% to 15%. Vaping dropped from 29% to 13%. Non-prescription drug misuse declined from 12 to 9%. And at the same time, protective factors, those shock absorbers that help a young person build resiliency, that's rising. 88% of students say they feel loved and supported by their families. More students report, yeah, that's a lot, 88%. Now, more students report meaningful intervention from adults at school, and more youth say that they have supportive adults outside their home. It tells us that young people feel like they matter, and it gives me hope for the future. And it shows that Maine is taking control of its story, its narrative, and its future. And this is what investing in the future looks like. It means investing in upstream prevention and investing in our young families and our kids. Building protective factors early, strengthening resilience, preventing substance misuse, chronic illness, and mental health crises before they take root. These numbers represent people, someone we know, someone we care about, someone we love. And how we got here matters. You know, real progress happens when we ground our work in evidence-based practices and genuinely listen to and co-create with people who have lived experience. Now, 2 programs show this in action. And I know there's many more programs, so I'm not doing I'm not doing the comprehensive portfolio any justice, but I'm gonna highlight 2 that show this in action. Syringe service programs, where they pair evidence with compassion to build stronger communities, and work being done by our Maine Prevention Network. Now, this is a network of collaborative partners, coalitions that span across Maine to bring prevention services to students and communities where they are. Now, with our harm reduction work and our syringe service programs, they demonstrate a humane, person-centered response. They create spaces where people feel safe, seen, and respected, and oftentimes for the very first time. Trust grows, health needs are met, and people take their next step towards recovery, medical care, and stability. So here's one story that was shared with us, and it's a privilege for me to be able to share this. One person had been reusing injection supplies because he didn't feel comfortable leaving home to access services. But through a steady relationship and continued outreach from one of our option liaisons, he eventually visited the syringe service program with a family member and enrolled, and then began returning regularly, and that's what matters. And as trust grew, he agreed to meet one of the community paramedicine program's dispatched physicians at one of our SSP sites, where, receiving care in a familiar, trusted environment, this allowed him to address infectious disease concerns, initiate treatment, and connect to ongoing care. Now, today, he's halfway through hepatitis C treatment and successfully linked to primary care and to a community that cares for him. This story highlights how SSPs can serve as an entry point to healthcare, but it also shows the impact of collaboration across multiple organizations on the ground, weaving together outreach, risk reduction, medical care, and care coordination to improve outcomes and build trust. And I've traveled across public health districts, across the counties here in Maine over the last more than 2.5 years at this point. And these are the stories that I hear often, a common thread happening town to town to town with difficult discussions happening among multiple different partners and community members. Now, the other program that I wanted to highlight was the work being done by our Maine Prevention Network. Our youth-focused work through the Maine Prevention Network shows how forward prevention is already shaping a healthier future. For example, Maine Prevention Network partners with supporting youth-led prevention work and youth leadership activities through youth advisory boards with a focus on youth-friendly spaces to support connection to community and mattering. Notice the emphasis on youth and bringing youth to the table. And together, these programs show who we are, a state committed to meeting people where they are while also boldly investing in the future. And as I close, I'm going to share one story and why these stories matter. Now, for those who know, I am a clinician, but I was shaped by training, but also by my patient interactions. As an intern, I trained at a hospital where there was an HIV floor, because we had so much HIV and so many people dealing with opportunistic infections as a result of AIDS. Part of this as an intern, it's also my responsibility to put in IVs every time an IV fell out. So I recall one interaction where I met V, this gentleman, I'll call him V, for the very first time. And it was my responsibility to put his IV back in. So I walk into the room, and already he was, one, not feeling well, so he was angry. But he was angry with me too, because I was not very good at putting in IVs. I tried, but he had so much scarring in his veins that I struggled. With the help of the nurse and my senior residents, eventually I was able to do this, but he was, for good reason, frustrated and angry with me. But I was a young intern, and I too was frustrated and annoyed. And so over time, every time I had to go into that room, I dreaded it, and I bet you he dreaded seeing my face. But, he kept coming back, because HIV care then was not the same as HIV care now, where there's more innovative treatment. And every time he came back, and each time his body failed, at first he was annoyed by me. Every time he saw me, I'm pretty sure he was disappointed, but I was there. I couldn't go anywhere, through year 1, 2, 3 of my training. But he kept showing up, I kept showing up, and over time, he became kinder. Those layers started to fall away, and guess what? I also became kinder. And my hardness and layers fell away. And the acerbic tongue that he had went away too. So as he started to share more, I started to become more patient, and I started to listen. And when I would see him, it started to change by my last year, when he was readmitted again because his body was failing and his organs were failing. I remember showing up, and for the first time, I didn't dread it, he didn't dread it, he smiled and I smiled. Years later, I learned that his heart has stopped and he coded. And knowing him, this big guy who did code multiple times where his heart did stop, he always came back, he always bounced back, and he was so resilient like that. But at the end of this story, I learned that he didn't come back. And I felt a loss that I didn't expect to feel. And these are the types of stories that you carry with you, that changes you, but also changed me for the better. Now, our progress here in Maine, those numbers that we celebrate, this is what happens when a state leads with evidence and data, but it's also with love for the community and for love for its future self. So, as I close for real, Gordon, with love and gratitude, I want to welcome you all, and I am so grateful for the work that you do. Thank you.
It's kind of a universal truth of our summits that no one pays any attention to what the number of minutes I tell them they have. And that, that's okay. These are powerful words and powerful messages, and I'm so appreciative for the language and the messages being delivered is that we have your back. You do the work, and we have your back, and it's not going to stop. So thank you. So recovery isn't about just the person, of course. It's about the family. It's about the community too. But we didn't think we could start off our Voices of Recovery today better than bringing back our voices from last year, Katie and Alan Burgess from our beautiful recovery center in Sangerville. And many of you who were there last year will remember their beautiful story about family and the impact of substance use on the family. And I am so appreciative that they will agree. It's not everyone that can stand up before 1,100 people and tell this very personal story. So I saw Katie and Alan. I'm sure you are out there nearby with your friends from Sangerville and Piscataquis County. So would you make your way up to the podium and to a rousing applause? Thank you.
Good morning. My name is Alan Burgess. I am the program manager at the Recovery Wellness Community Center, and I am a person in recovery. I'm standing here today in awe of a moment that at one time seemed so unfathomable that any reasonable person would have laughed at the idea of it. I want to thank Gordon Smith for inviting my wife and I back here again. It's an honor that I do not take lightly. As a matter of fact, if I try to describe it, my words will fall short. At one time, my life was falling apart. The idea of making new friends or any kind of life for myself had become a lost cause in my mind. I knew that recovery was not possible for me because I had been trying. I had been trying everything I could think of. Well, everything but asking for help. But that was not an option. Help would mean telling my family there was a problem. I could not and would not ever do that. That was a vow that I made to myself. It's interesting when I look back at it now, though, because I didn't know what help looked like. I had never seen it before. I had never been exposed to recovery. When I tell my story, I use words like substance use disorder and recovery. Those are words that are so common in my vocabulary now. But I know for sure when I was thinking of how I would stop doing drugs, I was not thinking of it in terms of recovery. I was thinking, I need to stop using dope, plain and simple. The fact that I wasn't stopping meant I didn't love my family. It meant I wasn't trying hard enough. If I cared more, I would stop. So there I'd be, smoking on my back porch, listening to some 80s movie song like Eye of the Tiger, and telling myself tomorrow is day one of no heroin. Needless to say, that never, ever worked. The one thing I needed to do was the one thing I refused to do. Tell my wife. I felt too much shame. Those of us in recovery know how powerful shame is. I thought it made more sense to die clinging to this addiction than to look at the people that love me the most and tell them I needed help. I will never forget the day I finally told the truth. It was June 25th, 2019. That's my recovery date. That's the day my journey of sobriety started. I had lost my job and I was out of options. I told my wife that my life was falling apart and I needed help. I think sometimes when I talk about my date of recovery, a picture starts to be painted of the day that I took my power back, the day I decided enough was enough. But those of us who have experienced a day like that know that it is rarely a good day. Rarely is it a day where we feel motivated and excited to embark on a journey. June 25th, 2019 was the absolute worst day of my life. It was the day I broke my family's heart. The day I told them that I had a problem that I believed definitely had no solution. It was hard. I had to leave. I will never forget that night I spent on my friend's couch with his Pomeranian on my head. But something powerful and inspiring did happen that day, because my wife, who I was quite sure would never speak to me again, texted me a hotline number, a number I called. They told me I could find a support meeting at this time in this place. They said I needed to bring nothing but the shirt on my back, and that was good because that's all I had. Right then, right there, that's where I found the thing that would save my life and ultimately lead me to my future job. And the thing outside of my family that I am most passionate about. That thing, of course, is peer recovery. That was just over 7 years ago, and here we are. My wife and I sharing a stage to discuss what we have learned and do our best to contribute to this movement that saves lives every day. Over the last 7 years, I have learned how many different pathways of recovery exist and how many people truly care. What an amazing thing to be a part of. This huge orchestra that makes a beautiful song when we all play our own instruments. Our strength is in our diversity as well as our willingness to work together. I wonder how many people in this room helped my recovery before I ever picked up a drug. People that set the table so I could find it when I was ready. I know you are out there. We may never know exactly how, and that is the beauty of the work that we do. It matters even if we don't always get to see it. I feel it when we come together like this. I'm grateful and proud to be a member of the Maine recovery community. As I speak now, I'm looking at people that have encouraged me, offered me advice, or maybe just listened. Because sometimes it's stressful, sometimes it's fun, and sometimes I feel like I have no idea what I'm doing. However I may feel in any given moment, I can't imagine ever doing anything else. Thank you.
Hi, everyone. For those of you who weren't here last year, my name is Katie, and I spoke about being an affected other. I shared my experience of being married to someone struggling with substance use disorder and the complicated emotions that come with loving someone through active addiction and recovery. Last year, I talked a lot about pain, but this year, I want to talk about hope. Because if there's one thing I've learned, is that hope looks very different than I thought it would. When I was younger, I thought hope meant that bad things wouldn't happen. I thought hope meant my husband would never develop a substance use disorder. I thought hope meant protecting my children from experiencing hurt. But life taught me something different. Hope is not the absence of struggle. Hope is believing that healing is possible even when struggle exists. A few years ago, if you had told me I would stand on stage and talk openly about addiction, recovery, and my family's journey, I would have laughed or cried, probably both. At the time, my world felt like it was falling apart. The future I had planned was gone. The life I thought I was living wasn't the life I was actually living. And I honestly didn't know if my family would survive it, but we did. Not because there was some magical moment where everything became easy, not because recovery fixed everything overnight, not because trust instantly returned. We survived because every day people chose to show up. My husband showed up, my daughter showed up, I showed up. Some days showing up looked like attending meetings, some days it looked like going to therapy, some days it looked like difficult conversations, some days it looked like forgiveness, and some days it simply looked like trying to get through the next 24 hours. Hope wasn't found in the big moments, it was found in the small ones. It was found in the ordinary Tuesday nights, in honest conversations around the dinner table, in laughter returning to our home, in plans being made and actually kept. In realizing we weren't just surviving anymore, we were living. One of the biggest lessons I've learned is that healing isn't just for the person in recovery. Healing belongs to all of us. The spouses, the parents, the children, the siblings, the friends, the affected others. For a long time, I thought my job was to hold everything together, to control outcomes, to prevent disaster, to carry everyone's burdens. But hope entered my life when I finally understood that healing wasn't my responsibility alone. I could support the people I love without carrying them. I could love someone while allowing them to do their own work. And I could do my own work too. I often think about the ripple effect I spoke about last year, how addiction spreads outwards and affects everyone around it. But recovery has a ripple effect too. Recovery creates healthier families. Recovery creates stronger relationships. Recovery creates honest conversation. Recovery creates opportunities for people to become who they were always meant to be. Today, my family isn't perfect. We still have hard days. We still have scars. There are still moments when fear sneaks in and reminds me of where we've been. But those scars tell a different story now. They remind me of what we've overcome. They remind me that people can change. They remind me that families can heal. They remind me that recovery works. Most importantly, they remind me that hope is stronger than I ever gave it credit for. So if you're sitting here today as an affected other, wondering if things can get better, I want you to hear this. Hope is not naive. Hope is not pretending that everything is okay. Hope is not ignoring reality. Hope is choosing to believe that today's circumstances do not get the final say. Maybe your loved one is in active addiction. Maybe they're newly in recovery. Maybe you're trying to rebuild trust. Maybe you're simply exhausted. Wherever you are, there is hope. Not because the road is easy, but because none of us have to walk it alone. When I look around this room, I don't just see people who have been hurt by addiction. I see people who have survived it. I see people who have fought for themselves and the people they love. I see people who understand resilience in a way that many never will. And I see people carrying hope for one another until they are strong enough to carry it themselves. Thank you.
Thank you, Katie and Alan. It takes a lot of courage to do that, and thank you. And I think your family is just perfect, Katie. I think you were wrong on that point. These two beautiful visions in yellow coming to my left are going to share some moments with you, and I'm so appreciative. Mrs. Melissa O'Neill Lowe is from the Department of Education. She formerly worked in the governor's office where we got a chance to work together. And it was the Department of Education that recommended our keynote speaker to talk about hope. And this is her second trip to Maine this year, at least. And hope is the theme, and Catherine's going to deliver the message of hope. Melissa, Missy to her friends, also has I think, a little story she's going to share with you, but a very meaningful one. So my friend Missy O'Neill Lowe, and then for the purpose of introducing our keynote speaker.
What Gordon failed to tell me is that my head was going to be on this jumbotron this morning. So, wow. Hope. It's a simple word, 4 letters, and we say it all the time. We hope someone gets better. We hope a family heals. We hope a child finds their way. We hope tomorrow looks different than today. But hope doesn't happen by accident. Hope is built. It's built through compassion, through service, through people who refuse to give up on others. Good morning, everyone. My name is Melissa O'Neill Lowe, and I'm the Director of Strategic Initiatives and Constituent Affairs at the Maine Department of Education. It is such an honor to be here with you all this morning. Wow. I'd be remiss, though, if before I introduce our keynote speaker this morning, if I didn't take a moment to recognize someone that I respect very much, value, and consider a friend, that has spent the last 8 years helping Maine and all of you build hope. I've had the privilege of working closely with Gordon, first in my role in the governor's office as the director of boards and commissions, where I relied on him heavily, and again in my current role at the Maine Department of Education. Because our work has continued to overlap, it's allowed me countless opportunities to witness his unwavering commitment to the people of Maine and to every one of you sitting here today. He's been a tireless advocate, a convener, and a champion, reminding us that behind every statistic is a person, a family, and a story. As many of you are aware, this is Gordon's final Opioid Response Summit before his retirement. I know that I likely speak for everybody here in this room today when I say, Gordon, thank you for your leadership, your compassion, your steadfast belief that recovery is possible and hope is not just a four-letter word. So, that brings me to today's keynote speaker, which brings me so much joy and so much hope. Catherine Getsky is the CEO and Chief Hope Officer of the Shine Hope Company. She's an internationally recognized hope scientist, global mental health advocate, and the author of the biggest little book about hope. Her work has been recognized by organizations around the world. It is grounded in decades of personal research together with lived experiences that demonstrate that hope is indeed measurable and teachable. Catherine also represents the World Federation for Mental Health at the United Nations and helped advance the International Day of Hope that was just celebrated on Sunday, July 12th. Those accomplishments alone would make Catherine an extraordinary keynote speaker today. However, they aren't why I am so honored to introduce her today. I first met Catherine last February during our Maine Department of Education's Winter Wellness Summit, where we connected almost immediately. I mean, the dresses, it wasn't planned. So there was a connection for sure. Her bright, yellow, sunshiny spirit is truly infectious, as you will all get to see very shortly, and it's why I'm wearing yellow today. At the time when Catherine and I met, my own family had found itself navigating a deeply personal, very real, and very lived challenge. Little did I know the role of this new person that had just walked in my life would play. Catherine didn't hesitate, even though we had just met. She made time, she listened, she witnessed my fear, but most importantly, she helped me replace that fear with understanding and, most importantly, education. She armed me with knowledge, perspective, and compassion at a time where all three were desperately needed, explaining to me that this was not the fault of anyone, and illuminated for me the psychology behind and between hopelessness and hope. And that hopelessness does not equate to or define us in our darkest hours. That is who Catherine is. She simply doesn't teach hope, she lives it. As we all gather here today, whether we work in healthcare, education, law enforcement, government, treatment prevention, recovery, or community advocacy, we are united by one belief that people can heal, that lives can change, that tomorrow can be different from today. Because hope isn't just something we wish for, it's something we build. It's something that your keynote speaker, Catherine Getsky, practices each and every single day. Hope is indeed a contagion, and it is why I'm so excited and honored to be here with you all today for you to witness firsthand just how contagious hope can be. Please join me in giving a warm Maine welcome to my friend, the matriarch of hope, Catherine Getsky.
I love you so much. Yes. Okay, we have to take a selfie. I'm sorry, this is just too historic. Yes, with all of you. Sorry, Gordon. Gordon, you want to get in it? No. Amazing. Wow. so touching and so grateful for you, Melissa. Incredible, and so incredible to be here with all of you today. I am here, yes, to talk about hope as the antidote and share with you my own experience, strength, and hope. So thank you so much for having me. It's great to be back at Maine. Super excited to be here. My name is Catherine Getsky, as you all know, and my sobriety date is 7/20/2004. So I am a person, thank you. So, it's coming up in a couple days, 22 years. So this is very significant for me and very meaningful. I am a grateful recovering addict and alcoholic. So this is especially meaningful for me today to be talking to all of you. So this is a participatory presentation. I am going to share with you all I know about hope, my journey to get to hope, where I am today, and skills that you all can use and take home. I'm going to share everything I know around hopelessness and hope. So it is participatory. So if you don't know how to use a Mentimeter, you can either go to menti.com and put in the number 2259-4161. So this is, use your phones, or you can use that QR code. So I just want to get a pulse of the room. How hopeful does everyone feel right now? Where's our hope? Yay, amazing. All right, so this is not the validated scale. This is just to get a pulse of the room. And one thing I always say about this, no matter where you are on your hope journey, once you learn skills and tools, you can find your way from hopelessness to hope. And I'm going to teach you and share with you about my own journey for that. So we're at about a 7.8 right now, and people will still come in. And if you have any questions about doing that, but we're going to be doing participation throughout this presentation. All right, so what it was like. I'm going to talk about that first. I grew up in Chicago, a suburb called Oak Park, Illinois. I had two older brothers, or have two older brothers. One's name is Fred and one's name is Arnold. And there's a picture of myself and my dad. Mom and dad were married. I was super close with my dad. So he was a retail banker. He knew Sam Walton, which was, I thought, amazing. We used to go to Walmart annual meetings. I learned all about retail as a very young kid. I'd go to his bank on the weekends. I had a super strong bond with my dad. And also my dad struggled a lot. He struggled with his temper. He struggled with anger. And I had a hard time navigating that because this was someone I loved so, so much, and someone that was also very angry and got very activated very easily. So it was there was a lot of trauma happening in the household. And then when I was 18 years old, I was a freshman in college, my dad died by suicide. And it shook my entire world. But that's not when my addiction started. My addiction started much earlier. I was probably 9 or 10 or 11 when I started drinking, and I got into a liquor cabinet and I just drank straight gin. And I just remember that feeling through my body of absolute, I felt okay. For the first time, I just felt my nervous system just calmed right down. And that addiction took off throughout high school, college, drank significantly. And then when I lost my dad, it just got worse. And I was a binge drinker and a blackout drinker. And, it was a rough journey. And then I would go from one addiction I found to the next addiction, to the next addiction, to the next addiction. And I would fix one thing and then I would have another problem. I would be compulsive or obsessive about something else. And so I, went on this journey. I then, in my early 20s, I had my own suicide attempt. I was not in a suicidal state. I wasn't in a major depressive episode. I had an experience. I was very intoxicated, and it was a very impulsive thing to do. And it took me 10 years to tell anyone else about it. Thankfully, I got an undergrad degree. I still, worked. I got an international MBA. I worked for big companies, and I seemed to manage my addictions somehow, made it through. And I decided when I was starting I started my own company and brand called The Mood Factory. The brand was called Mood Lights. This was over, almost 22 years ago. And I wanted to support a nonprofit in the mental health space because of how much it had taken from me. And so I looked at other nonprofits and I found that mental health had a real branding issue. The images that people were using, they were, hiding in a closet or looking so alone and isolated. And I thought that's not really what depression and anxiety look like. And then I learned that less than 25% of people with anxiety and depression were getting treated, and it's very treatable. So I thought, well, I guess I'll start my own nonprofit. And that is what I did. I started the International Foundation for Research and Education on Depression. And I started that on my sobriety date. Now, I didn't have some catastrophic event happen when I got sober. There were enough problems throughout my life that alcohol and substances caused. But why I got sober is because I started looking at the research, and doctors told me I was at a very high risk of suicide because of all of the risk factors. And so I thought, well, alcohol, substances increase your risk of suicide exponentially. And if I'm going to start a nonprofit in the mental health space, I better start living according to what I'm teaching. And so I committed to my recovery on that date. I did therapy, I did medication, I did a year-long program that we went through the steps in this program. And as we've heard, everyone's recovery journey is different. Everyone has their own path, their own way of going. And my aim for everyone is to help you feel better, to improve, and we'll talk about your hope, and to get to a place where you want to go. And so, the recovery journey is so individual. But when I started, I wasn't satisfied with what was currently happening in the recovery space because there's such a high relapse rate. And I thought, I don't want to relapse. So I got really committed to figuring out everything I could about recovery and addiction, depression, suicide, anxiety. So I started this nonprofit and I started traveling around the world. I joined the global mental health movement. I'm a brand expert, marketing expert, business strategist. And so I'd attend every conference I can get to and listen to all of these leading experts in global mental health about what they're telling me and everyone about addiction. And here's what I learned. I'm told by doctors I'm at a high risk of suicide, and then I'm told, restrict your access to means, and so lock up your guns, your medications, all of that, and here's an 800 number. And that was, at the time, the method for me for suicide prevention, or in what they were teaching. Now, those are great for time of crisis, yet I knew for me that was not going to keep me here. Those methods weren't helpful for me. And I also knew that if you want to prevent something, you have to get to the root cause of it. And so I set out on a journey to understand the root cause of suicide. And that's what I have been doing for the last several years. So I'm going to take you through now what I know about that. Hopelessness is the idea that things are bad and there's nothing I can do about it. That's all kind of what hopelessness is, and then we'll talk about hope. And what I started learning is there's this global epidemic of hopelessness. I found the Maine stats earlier to be very inspiring. There's a CDC did a national study recently that 57% of our teen girls identify with persistent hopelessness, over 40% of our youth. And if that doesn't scare us and shock us and drive us to action, I don't know what will. Over half of our girls are identifying with this persistent state of hopelessness. We know hopelessness leads to all risky behaviors in youth and addiction. I was in the most hopeless states as I chose substances. And the deeper I got in that hole, the more that hopelessness just took over. Loneliness, anxiety and depression. Again, hopelessness, as I got into the literature, came up as that single consistent predictor of suicide. And to me, that was incredible information, because if it's hopelessness, it's not anxiety, it's not depression, it's hopelessness, then if I can understand hopelessness, that is how we are going to prevent suicide. And so I set out to figure out hopelessness, to understand it. And what I came to learn, it's a negative expectation about the self and the future, and it's made up of two key ingredients: emotional despair, so you feel sad, angry, afraid, coupled with a sense of helplessness, so you feel powerless to do anything about it. So, and again, it's the single consistent predictor of all risky behaviors in youth. So I thought, why doesn't everyone know what this is, and why doesn't everyone know how to get to hope? Hope can feel, when I lost my dad, my whole future, like, who's gonna walk me down? Like, all of these things kept me in this persistent state of hopelessness. And then when I broke hopelessness down, it's actually very normal. And hopelessness is the primary symptom of depression. So to me, symptom was that clue. It's a moment in time. It's something that happens over and over. And if it's a symptom and a moment in time, if you can understand that moment and learn to manage that moment and learn how to get to hope, get moving back towards hope, that is how you prevent suicide. So when you look at these two, the helplessness up there, I thought, okay, what's the opposite of helplessness? Like, how do we get out? Well, you're taking inspired action. So to me, that was high hope. You're moving from helplessness and into action. And emotional despair, sadness, anger, fear, how do we get out of that and get to having positive feelings? So to me, it was amazing, because you can always manage your helplessness and get to action. Like, you can be taught skills for how to do that. Might not be the action that you want, or it might be taking no action, yet you can always learn. And you can always get out of despair. You can always manage your negative emotional states and get to feeling better. And sometimes it just takes time and patience and courage and all of the things we know in recovery. So then I set out on a mission to ensure all knew how to hope. And what I learned too about hopelessness, there are these micro moments of hopelessness. We can't get something working in technology, and we have that, fear, and then we have that sense of powerlessness. And it's how do we navigate these moments? They're all unconsciously happening, and it's about making it conscious and then being proactive about how we move towards hope. There are also systemic reasons for hopelessness, and if you focus on that, it will keep you stuck in your despair and your sense of helplessness unless you learn, again, how am I going to manage my anger, fear, sadness about this, and how am I going to get out of helplessness into action? Where is my power in this situation? Because the more we focus on things that we can't control, the more we inadvertently stay in those cycles of hopelessness. Hope, on the other hand, is the belief the future can be better than today, and that I and we have the power to make it so. I looked at this definition and I thought, this impacts everything. If you don't believe that you can create a better future and that you don't have the power to make it so, what are we all moving towards? And so when I started my programming, what I did is I thought, okay, I'm going to teach people how to hope, and I'm going to test out the theory that you can teach hope. And so I created a program for young kids, initially 7 to 11-year-olds, because of the increase in anxiety and depressive symptoms that happen in those young years, and came up with lessons. I looked at hope scales. There were validated hope scales, and then I took these validated hope scales, and then I looked at the definition of hope. And I pulled out the key words in that, and I thought, if we're going to teach hope, and then I also looked at hopelessness and emotional despair and helplessness. So creating a program to teach how we move through that towards hope. Because the incredible thing that I didn't know is that they were measuring hope, scientists were measuring hope, and they knew all of the positive outcomes associated with hope, but they weren't teaching you how to hope. And when you have the biggest challenges in your life, How do you navigate the moments of hopelessness and get towards hope? So I set out to prove out my theory that you could teach hope as a skill, created a program, and then went studying it all over the world. Ulster University in Northern Ireland. It was just starting out with this concept, but then we did the research with Ulster and were able to show, yes, over 12 weeks, we could teach these students in school hope science and how to be hopeful. And as we increased hope in these youth, symptoms of anxiety, depression, violence decreased, connection went up, all of these positive things. And I thought, well, then this is the most important thing in the world I can be doing. So I put my other company to the side, and I've been really focused on understanding hopelessness and operationalizing it globally, because I believe there's no more important thing and skill we can learn. And especially for those in recovery, hope has played such a key role in my own recovery. So this is the hope scale. It's a Snyder hope scale. It's validated. They have a children's one. There are some other hope scales as well. We like this one because of all the research that's published on the outcomes as it relates to hope. They just did a study in Australia, the first longitudinal study on hope, and it predicts all, human flourishing. It's no big surprise to me, yet it's great to see this research validated. We know the power of hope in youth, GPA, sports performance, graduation rates, how well they do in school, if they go to college, safety, all of these things. Increased soccer reaction time for all of you soccer folks, and decrease risky behaviors. So if we can increase hope, all of these other things decrease. So it's so powerful. And I just published new research on hope as a strategy in global development, sustainable development. So, we looked at all of these studies, and we looked at all the sustainable development goals and mapped hope to each of them. So a lot of research cited here. I like to, I want outcomes in what I do. I want evidence-based approaches to how we tackle this global mental health crisis, addiction crisis, and violence. So this is the framework that we then created. I'm going to take you through the framework and share this is what I've learned and what we know, and it differs a bit from traditional hope science, but it's evolving that, and it's really coming at it from hopelessness. So SHINE is a mnemonic for how we cultivate hope in our lives. And this is my friend Grant Denton in Reno, Nevada. He's got an incredible story, but we have people write their stories. And we do a lot of stories in recovery, and one of my biggest challenges with that is a lot of people spend a lot of time on all of the problems that they had in their early, and we can relate to them, but we need to know the solutions. What's working? What are people doing in their lives that's working in our recovery? How are we getting better? How are we supporting each other and getting better? I want to know what's working for each and every one of the people that have come from the hardest places and are getting there. So we have this format where you write your challenge, what your challenge is, and then the specific skills that you used and navigated to get through that challenge. So these are the 5 keys to hope, and this is where you're going to participate a little bit. I'll take you through them, and then we'll ask you to share your own. So stress skills. This is how we identify and manage our stress response. And to me, this is just the hallmark of addiction. This was my problem. This was my dad's problem. This is why people are in jail, and this is why we pick up and use. We have a physiological response to triggers in our environment. A physiological stress response. So when someone does something or says something, or we read something, or we have this trigger, and stress hormones flood our bodies. So it takes 90 seconds for those stress hormones to be released after the point of trigger. Now, the stress hormones keep us in the downstairs brain where we can't access our frontal lobe and our critical thinking and our ability to solve problems and our ability to make good decisions. So we're triggered, we can't access our thinking brain, we're reactive, we pick up, we use, and we wonder why we keep doing it. Well, there's a physiological reason for it. So one of the key things for me was learning how to, feel my trigger. You can feel them when they're happening and intervene before I use anything. so many substances I've had to create, and it's all because I was just wanting that relief, that instant relief, but it takes 90 seconds. And it's not just a decision I make. I'm not making a decision because I can't actually access that part of my brain that makes healthy, good decisions. So learning how to manage and navigate that stress response is, to me, one of the most important things in our recovery journey. It was important for me. And my dad had this stress response. He'd get triggered, he'd go to rage. And I could see it was physiological with him. Like, he wasn't thinking rational. You couldn't connect with him. You couldn't. And kids we work with in prison, they're saying, like, I keep doing the same thing. I don't understand why. Yeah, there's a biological reason for it. So how do we intervene biologically? And to me, bringing in the biology of it is very helpful in reducing stigma and shame around why we keep repeating the same thing. So identifying and manage our stress response with stress skills. And this is the downstairs brain that dominates, the trigger. 90 seconds. If you've ever been triggered by anything and try to wait 90 seconds, it's like 10 years, you know? It feels like forever. And it's from the point of last trigger. So basically, anything you do in those 90 seconds is probably gonna be a really unhealthy decision. So learning how to wait that out through things like breathing, learning how to meditate so you can better intercept that stress response, going for a walk, taking a break, anything to keep you from not engaging when you're from that activated place. So I'd like to know from all of you, and I'll also send this presentation after. We're gonna get everyone's brilliant ideas on how we navigate our stress response for impulse control. So I want you to put into Mentimeter. It's menti.com, same place, 2259-4161. Be as creative as you want to be. How are we navigating? How are people doing this right now? Like, what are the skills? Because this is how we learn. This is how we connect and figure out solutions that maybe we haven't thought of. Tree pose, I love that. Humming a song, there's great research around humming. Breath, deep breathing, walk the dog, take a time out. Piano, not today. Time with pets, painting, guitar, forgiveness. I mean, to me, like, I have to remember all of these things. You know, another thing now that's become a challenge for me is texting. I'm reactive and I text something, and it's like, I have to learn how to constantly regulate it. You know, Melissa said, I'm a constant practitioner of everything I teach, and just because I know it doesn't mean I'm perfect at it, but I'm constantly working on it. This is amazing. And then, you know, we learn together, but to me, this is so important for hope overall, is learning how to identify and manage your stress response and having healthy interventions ready for you and finding what works for you, you know? Amazing. We go to happiness habits. So we need happy hormones. We have stress hormones. Stress keeps us in our downstairs brain. If we have too much stress, we get burnt out. Well, what are happiness hormones? Happy hormones are the hormones that help us feel good, that keep us in the upstairs brain where we can problem solve, when we can think critically. And so how are we getting these? You know, for me, when I lost my dad, I stopped doing the things that brought me joy, and I was drinking and, you know, just all of these unhealthy behaviors because I wanted to feel better. And the interesting thing about happy hormones is if you're violent, when you're violent, you get a hit of dopamine. When you choose addictive substances, that gives you that immediate relief. There's actually a chemical reason for this. And so it's learning how to replace the substances with healthier things that give you what you want, what your body craves, and what your body needs. So having a morning routine, utilizing strengths, finding purpose, these are all things that generate these happy hormones for us. Gratitude, purposeful living, volunteering, service work, family and friends, wonder and awe, experiencing wonder and awe, time in nature. You know, it's hard to want to do these when you're in pain, and yet when you're in pain is the time you need to do these the most, because your body needs these. We need these to be engaged and healthy in life. And so this goes through more of the happy hormones, and I would like to know from all of you, do you have non-negotiable happiness happiness habits. So what are things that are non-negotiable for you that you will always do no matter what? Or do you have a list of those? And if you don't, I encourage you, stop working. That's hilarious. Oh my gosh. Luke Combs session, I love it. Exercise, ride my horse, going to the gym, golf, horse videos, pets, laughter is so good for you. Reading, good sleep, absolutely. I mean, sleep for me, my nutrition, exercise. If I don't get my exercise, like my dopamine, my serotonin is depleted. I mean, I have to replace. And that's actually how I quit smoking. I had to replace it with running. Like I had to replace that habit with something else that was healthier. Gardening, therapy, writing, prayer. Prayer is an incredible, happiness habit. Time alone. And there's so much research on all of these. And if you look at these, you'll also notice they're all most of them are free. You can do all of these on your own. So without paying anything, these are all, our body can generate all of these things within us, which I find fascinating. I mean, I've been super off medications, therapy the last 10 years because I practice these every day and I'm very consistent about it. And to me, this is how I keep myself here. This is how I'm saving my life. Inspired actions are how do we move towards goal? How do we get out of our helplessness and into actions? And when you're in that space of desperation, like sometimes it's no action or doing the next right action. And to me, it's day by day, it's minute by minute, it's hour by hour. But what are we doing? How are we moving towards a life, creating a life that we want? And so we talk about different ways to set goals, intrinsic goals that are meaningful to us as opposed to extrinsic. We're doing it for money or for fame we know that meaning is so important to creating a hopeful life. SMART goals, so, when I lost my dad, I wanted my dad back. And if I go through the SMART goal process of having my dad here, it becomes very clear, specific, relevant, attainable, specific, measurable, attainable, relevant, and time-bound. So is it attainable? No, I can't have my dad here, but what did I want? I wanted mentors in my life. I wanted a father-like figure. And so I worked to build those connections. So I had to re-goal, and that's the thing about hope. Sometimes we don't get what we hope for, and we have to learn how to move towards something else, re-goal, create a new hope, because something doesn't work out. And a really interesting thing about the motivation loop, which we get motivated by taking the first step. So I don't think, hey, I am so excited to go to the gym today. I think, I'm gonna go to the gym, and I get to the gym, and I start running, and I'm like, oh, this feels good, I wanna do more. So motivation doesn't come by our thought, it comes by our doing. We have to do the first thing before we then become motivated, and that's a lot of challenge with people moving to recovery. We think that we're gonna be just motivated to not do that, but it actually, you have to start doing the work, and that is what feeds your motivation. So how do you all take the first step when it's hard? And what are you seeing in the communities of recovery? How do you get that first step moving? How do you get taking inspired actions out of my wife makes me, that should be like the big one, right? Just do it. Finding a specific task, being determined, eating chocolate, that's hilarious. Family support, have a conversation. Self-talk. Self-talk is so critical. Just do it. Nike would like this for. Accountability partners. Sign up. Finding a specific task. Do it anyway. I mean, that's how do we get going? How do we get out of our helplessness and into action? And knowing that, we don't just automatically want to get there. We have to do things that then actually get us taking that first step. And as we take that first step, it feeds off itself. Really helpful. Prayer, really good. Accountability partner. And we'll talk about that in a second too. Okay, I love that. And keep Keep adding. And I'm going to send these out as JPEGs and put them up on your wall, put them up in your recovery centers. Like, we got to reinforce that we have to do these things if we want to keep moving towards recovery and towards hope. Nourishing networks is the end. So, creating healthy bidirectional networks with other people and with ourselves, and learning skills and tools to do that. The 5-to-1 rule is a really important rule, and it's a very challenging one. You have to say 5. If you want to have healthy relationships, you need to say 5 positive things for every criticism. And I play a lot of pickleball, so I teach this on the pickleball court with my partners. Like, if you want us to work well together, you're gonna have to say 5 things to every criticism on a shot I make or whatnot. But it's true in the workplace, in your relationships at home with your kids. We wanna be reinforcing and recognizing positive behavior and do less of the criticism. Compassion, the power of forgiveness, super important. So who is in your nourishing network? Who do you all have in your own nourishing network? Gossip in the group chat. Yes, my mom, my husband, family, trusted coworker, sister, my boss. In recovery, maybe it's your sponsor, your sponsee, work wife, dog. So that's the thing. In my nourishing networks, when I lived in Reno, Nevada, like, my wild horses were in my nourishing networks. But it's got, whoever you need, but we all need to feel connected, and we all need to feel nurtured. So that's a very important part of hope. And what I was going to say about goals, you're up to 95% more likely to achieve something if you write it down, so you write your plan down, and then you check in with someone regularly on your progress and your process and what you're doing. So accountability is so important for building hope and achieving what it is we want. The E in the shine is eliminating challenges. So how do we get rid of all the negative thinking patterns that our brain just does automatically? How do we become conscious of that and then intervene with skills that we've already talked about? So limiting beliefs. Beliefs, hope is the belief the future can be better than today and that I and we have the power to make it so. So your belief that you can create a better future is so important. And we're so trained to these negative, limiting beliefs of ourselves. There's something called the nocebo effect. So the placebo effect, you take a pill, you're told it's going to have a positive side effect. Over half the people have that positive experience, even if it's a sugar pill. The same thing, or the opposite thing, is true, the nocebo. So you're given a pill, it's a sugar pill, and I'm telling you, you might have a stomach ache, a headache. Half of the people will have those symptoms with just sugar. So your belief is so important. So you must believe that you can recover. And also, as therapists and as teachers and as doctors, our belief in those we're supporting is sometimes more predictive of outcomes than their own belief in themselves. So making sure you never give up your belief in someone's ability to create a better future for themselves. So how do you all eliminate your negative thinking patterns and beliefs? What do you do to switch? Medication, journaling, reality testing, counseling, gardening, willful ignorance, sports, healthy ways, yes, process them, talk to my partner, positive affirmations, and dance it out. So it's, you can use stress skills, happiness habits, people in your nourishing network, God, surrender, all of these things. So, but it's about becoming aware of these patterns. When the work we did in the prison youth, they're like, we do all of them. Like, we do everything. And I'm like, we all do everything. And we have some patterns that we do more than others. And it's about learning how to just identify it and then start intervening on it. All right. So hopeless is the belief that things are bad and there's nothing I and we can do about it. And I say you shine your way from hopelessness to hope. So when you look at the hope definition, again, in mapping shine, hope is the belief. So we use eliminating challenges to really improve our belief that the future, so we're taking inspired actions to our future, can be better. To create better, we use our stress skills and our happiness habits. that I and we, we need hope ourselves, and then we need collective hope, and we use nourishing networks to do that, have the power, and again, taking inspired actions to make it so. And that's how we get to the definition of hope. And I know we're all short on time, but I've mapped the 12-step framework to the SHINE framework. To me, the 12 steps became a part of, they were a part of my process in my early sobriety and later, and I love meetings and I love connection. But to me, it wasn't enough because I didn't like the data around success rate. So to me, bringing in the biology and the science to the actual practices has been a really important journey for myself. But you can take a look at that. And then, what it's like now. I'm doing the work that I love all over the world. I feel so blessed. I am so committed to my hope. I do all of the practices that I talk about. To reprogram my brain, I spent 6 months of 2 hours of meditation a day because I was so impulsive. I was so compulsive. I couldn't sit still, and that changed my life dramatically. So I've spoken at the United Nations. I work to get mental health in the Sustainable Development Goals. I've been in the Harvard boardroom talking about hope science, talking to anyone and everyone anywhere in the world that will listen, because I believe hope is so important to solving, and teaching hope is so important to solving, the global mental health, addiction, violence crisis. And we've been doing this programming all over the world. We use the sunflower as the international symbol of hope, hence the yellow dress. So I'm often in yellow because I'm usually doing hope stuff. Sunflowers are heliotropic. They follow the sun. And then when things get dark at night or cloudy, they turn and they face each other. And it's so important that we learn to do that. We know every child needs at least one trusted adult in their life. And sadly, a lot of our teachers report that half of the class can't identify one trusted adult. And this is predictive of so many outcomes. So ensuring all of our kids, I love the Maine stats on love because that is such an important component of hope. So we plant sunflowers all over the world. We're activating hope in education, so we're teaching hope as a skill. We're now, activating communities. Chicago is a hopeful city where we license our programs to the entire community. My aim is that I want to demystify hopelessness. Hopelessness is not a diagnosis. It's not a disease. It's a moment in time. And once you understand that it's a moment in time, and you can identify that moment, and you know that you have power to manage that moment and get towards hope, for me, everything changes in life. So that's our Hopeful Cities Ambassador. And yes, we got an International Day of Hope established at the UN. I've been working on this for years, and it's was such a challenge, and so grateful that it passed. I will report here, we had 161 countries vote in support of the day. Unfortunately, we had one country vote against it, which happened to be our own country. So making a public statement about why we don't need hope. So we have our work cut out for us. Hope is nonpartisan. It's something so critical. So to me, that just motivates me even more to get this work out into the world, because I believe, with hope, anything is possible. Excited about that day, July 12th. You can measure your hope at My Hope Score. Bring hopeful minds to your schools. Join us for the International Day of Hope. We have a lot of free resources that you can use to start learning about hope and teaching it in your community. And again, this is, to me, the truth about hopelessness. We hear the word hopelessness and we're so conditioned to think it's like you have to be in the worst of conditions to experience a moment of hopelessness. But we're all experiencing these moments all the time. It's normal. It's just unconscious. It's sadness. When's the last time you felt sadness and I can't do anything about it? Or or angry and I can't do anything about it? A lot of my childhood looking at my dad not being able to help him, so sad, so helpless, and then losing him in that final way was horrific for me. But I was not taught how to manage that moment in a healthier way and how to get back to hope. And so the moment can always be managed, and we can always shine our way from hopelessness to hope. So to wrap up, how's everyone doing now? Checking in. You're ready for this summit. I'm so excited for you all. It's such an honor to be here sharing my own experience, strength, and hope. I mean, I never imagined I would be running around the world teaching hope as a science. You know, I feel so blessed to honor my dad, not by his loss, but by what he had taught me and what he's now bringing to the world, because without his brilliant business expertise, his knowledge of strategy, operationalizing things, like I wouldn't be able to do this. And so I learned so much for him, and I get to carry his legacy forward in this way, as well as my mom, who's been a champion for me. So, all right, feeling hopeful. Are you guys ready for the day? Yes, the statistics shared earlier about the work being done in Maine, and that this is a massive group of people caring so much about recovery. It is so hard to see someone you love so much struggle and not be able to help them. And, you know, it drives us into our own state of hopelessness, our own sadness and our own helplessness, because we can't do anything about it. So if you're working with people in recovery, you've got to work on your own hope just as much as you teach them to work on theirs. So wonderful. Thank you so much for having me, everyone. Thank you.
We're going to start with one of our strongest voices of recovery, the amazing, incomparable Abby Frucci from Washington County. Abby, I could talk all morning about Abby and the work that she does at the Community Caring Collaborative and how influential she's been in our recovery-friendly community program in Washington County. But one of her standout activities has been to serve on the board of Arise, which is the organization that supports and promotes all our treatment courts across this country. You heard Sarah Squirrel this morning talk about the fact that we now have 14 different treatment courts in the state of Maine. But Abby, being a graduate of one of those programs, is the only person that's come through the program to serve on the Arise board, which is the national organization. She's about to complete 6 years of service and will be in Nashville in a few days for their national meeting. I am so proud of her. Abby Frucci.
Wonderful. Thank you so much, Gordon. I just want to start by saying there was a time in my life that when I stepped up to a podium and a microphone, it was followed by, "Yes, Your Honor." And I'm just glad today that's not why I'm here. So thank you as always for the opportunity to speak as a voice of recovery. It's absolutely an honor to be here today with so many colleagues and friends in the recovery community, the amazing work that you do. My name is Abby Frucci. I'm a lifelong resident of Washington County, Maine, and as many of you know, it's the easternmost county in our state and in the United States. It's geographically large, it's very rural, and it's deeply connected. It's absolutely a beautiful place. It's the bold coast, multi-generational families rooted in deep down east values. But also, like many rural communities, it's been significantly impacted by alcohol and substance use. And my story reflects that reality. I grew up in a home where alcoholism was present. There was hard work, but there was also a lot of chaos. As a child, I learned how to navigate both while trying to grow into myself. But today I don't want to focus on what happened to me. I want to focus on what happened around me, how people, how community helped me heal. So in alignment with today's theme, building hope, honoring progress, and inspiring change, in the discussion by Jackson Lab on the basis of biological addiction, I want to share how recovery has allowed me to break the multi-generational cycle and create different opportunities for my family. So I'm going to start by sharing a few pivotal moments in my life. The first one is July 17th, 2004, almost 22 years ago to this day. I myself was a 22-year-old with severe opioid use disorder, and I gave birth to my child. What should have been a moment of joy was filled with fear and shame. We spent the first part of his life in the neonatal intensive care unit. I still remember that overwhelming guilt. And yet today, later today, after this event, I'm traveling to Farmington to celebrate his 22nd birthday as he begins a life of his own with his partner. That's what recovery has made possible for us. So back to the story. Less than a year later, on June 15th, 2005, I was arrested by the Maine DEA with my infant in my arms. I was charged with Class B drug trafficking, and this is when my journey in recovery began. I spent 30 days in jail, only to find out what the next steps were, and I'm so grateful to say those next steps were treatment court. So if you follow along with my timeline, you'll see that I was close to missing my child's first birthday. This was an absolute moment of clarity for me. I was coming out of the fog, and I was really forced to ask myself, where has my addiction taken me? But how do I sum up the next 21 years? I can absolutely tell you this. I'm living a life that I could never imagine. I could have absolutely never imagined back then. I've been married to my best friend for 11 years. He's also a treatment court graduate. Together, we're raising 3 incredible children. I became a master's level social worker, dedicating my career to substance use response efforts locally, across our state, and nationally. We own a small business, and we live in our forever home on Bog Lake. But the real question is not what my life looks like now, it's the how, because I absolutely did not do this alone. When I started, I felt completely hopeless. It took me 10 years to even speak openly about my experience with maternal substance use. I had to ask myself, what did I have that my father and his father before him did not? Why did they lose their battles to alcohol use disorder when I found a path forward? And the answer to that is community. For more than 20 years, I have been surrounded by people who refuse to give up on me. A treatment court that provided both accountability and belief, a recovery community that showed me a different way to live, a school system that welcomed me in spite of my criminal record and pushed me to succeed, an employer that invested in me and is here today, giving me a chance even when I was unsure of myself, people who saw potential in me long before I could see it in myself. And that's what we're really talking about today when we're talking about addressing addiction. Understanding biology absolutely matters. Systems and strategies, they matter. They're part of my story. But healing happens in connection. It happens when people are met with accountability and compassion at the same time. It happens when we invest in long-term recovery and not just short-term sustainability. It happens when communities choose to see people not for their worst moments, but for their potential. Because recovery does more than change just one life. It changes families. It interrupts generational patterns. It creates new outcomes for next generations. And I can speak to that firsthand. Today, my children are growing up in a home filled with stability, connection, and hope, something that once absolutely felt out of reach. And that's the important work that all of you are doing. So as we continue today, building hope, honoring progress, and inspiring change, I ask that we keep people at the center of our discussions, because I am not the exception. I'm an example of what is possible when community, accountability, and opportunity come together. Thank you.
Thank you, Abby. That was an amazing story and great way to get us started today. Happy birthday to your son. So good morning and welcome everybody to the session titled Biological Basis of Addiction, Research Updates from the Jackson Laboratory. My name is Michael McKernan. I'm the Senior Director for Government Affairs and Community Relations at JAX, based in Bar Harbor. Remembering human stories is one of the important reasons why we participate in this summit and have now for several years in a row. We're really grateful for that opportunity. In most settings and most scientific meetings, there's usually a lot of scientists in the room, and there's sort of the token person from the community, the advocate. There are small groups, but usually the scales are very heavily tilted towards the scientists. It's a very familiar space for us. This really turns the tables on that. This gives us an opportunity as researchers, scientists, to hear directly from members of the community, from you all, to hear stories. And it's incredibly important and I think invigorating and centering for both myself and my colleagues. So I think that's a kind of a good preface to start. Jackson Laboratory, we are one of the largest employers in Eastern Maine. We're a very unique institution where we're sort of three things in one. We're a basic research institution, biomedical research institution with about 60 professors across a couple different institutes with hundreds of staff, including scientific technicians and specialists and a lot of graduate students and trainees. We're also an educational institution. We're very proud, for example, of several doctoral programs that we have, including in partnership with the University of Maine, with the University of Connecticut, and with Tufts University. And we're also very well known for our mice. We produce, we design, we distribute specialized tools, mouse models, for a range of human diseases. And these tools are used worldwide by scientists trying to investigate the origins of cancer, Alzheimer's, of course, addiction, substance use disorder, and many, many others. So that's kind of what we do at the Jackson Laboratory. So all this work is supported by nearly 3,000 colleagues worldwide and 1,500 employed in good jobs here in the state of Maine. So we've assembled an expert panel here today to discuss the biological basis of substance use disorder, including the genetics of addiction, overdose, and withdrawal. And while broad understanding of the biology of substance use disorder is critical, research is increasingly focused on personal genetics. How my genetic background, your genetic background, when combined with environment and other factors, provide important context for understanding how this disease manifests differently and may be treated differently in different patients. So as a panel, we know this is a very heterogeneous audience, including there are some other researchers in the room. There's certainly some physicians and clinicians in the room with deep knowledge of these biological topics. There are individuals with lived experience and individuals who have last encountered the word genetics in high school biology or maybe on YouTube, which is fine. We all share a goal to understand the opioid crisis from many angles, including through scientific research. So please ask any question, don't be shy. We don't have a mechanism in this room to come to a microphone and ask a question, so we do ask you to use our Slido mechanism. So log into Slido or take a picture of the QR code and type any question that you want, and then when we get to Q&A, I will moderate those questions. So what we'll do is we'll invite each speaker to come to the podium and talk about their research interests for about 15 minutes, and then we'll do Q&A at the end. I think we'll now get underway. Let me just do a quick introduction of our panel. So our first speaker will be Alyssa Chesler. Alyssa is a professor in the Jack Center for Addiction Biology and is Senior Director of Integrative Data Sciences based in Bar Harbor. Our second speaker in the middle is Jason Boubier. Jason is a senior research scientist, also in the Center for Addiction Biology at JAX in Bar Harbor. And our final speaker on the end, Jake Byerly. Jake is a postdoctoral associate in the laboratory of Vivek Kumar, also in the Center for Addiction Biology based in Bar Harbor. So this is a fantastic panel, and we'll get underway with Alyssa.
Thank you, Mike. Thank you for the introduction, and good morning, everyone. Happy to be here. What I wanted to talk today about was something that we've been learning over the decades of biology of addiction research, which is more about how we come to understand the nature of the role of genetics and variation in the biology of addiction. Substance use disorders are among the most complex of what we call complex diseases. When we say a complex disease, we mean multiple genes, multiple environmental factors, life experiences, development, all coming together and interacting to produce the outcome that is a disease, a disorder, a trait, a behavioral state. many, many effects coming together. Human genetics has revealed, at this point, hundreds, if not thousands of variants, differences in each of our DNA that are associated with our risk for these conditions and how they play out in our lives. And what we learned from mice and other models is different ways that we can understand, study, and characterize this complexity so that we can learn about those individual differences affecting each person in their own way. This is a graphic of all the roads that lead to Rome. And when we think about an individual with a substance use disorder, we can look at this and say everyone got there on their own journey. And that's true from the adverse life experiences, maybe great life experience, and a lot of biological predisposition, what drugs were available, when did you start using those drugs, how did those drugs interact with each other, and how did you respond to the effects of those drugs? All of these things come together in many unique paths, bringing us into the place that we are today. So it's not just one major genetic variant. Geneticists used to look for the smoking gun, but it's many thousands. And so here we have the first genome sequenced, trying to figure out what's happening here, and one of the biologists says, I think I found a corner piece. We know that only some people who use drugs develop a substance use disorder, and that role of the genetics is different for different drugs. So we can see that given exposure to a drug, nicotine, very highly addictive, alcohol, 23% of people using alcohol develop an alcohol use disorder, but opioids, cannabis, we all know these are addictive as well. And then if we look at a pair of twins, even those raised apart, there's a probability that if one twin develops a substance use disorder, the other one does as well. And we can see that even that varies differently for different drugs. So cocaine use disorders are very highly heritable. So one twin gets cocaine use disorder, the other twin may have it as well if they're both exposed to cocaine. Opioids, quite similarly. Even smoking, gambling, somewhat highly heritable, and the hallucinogens and other drugs are less highly heritable, but still to some extent, twins might share that. That's saying to us that there's a great role of biology and shared genetics in driving whether somebody is exposed to those drugs, develops that substance use disorder. So really, when we think about addiction biology, we're talking about many roads to many Romes, even the one here in Maine. What we learned from mouse genetics, we can look at each of these factors in isolation, in combination, and examine what biological variation is associated with which of these different traits. And we use techniques we call systems genetics to find the genes and variants associated with many, many of these traits. And we look at data from lots of different sources, including human genetic studies, mouse genetic studies, and other organisms in concert to try to best understand how we can characterize what's known from human populations. Now, historically, a lot of the behavior studies that are done in laboratory mice were done on a very few mouse strains, some very famous mouse strains. But there's a whole world of mouse strains out there, not everyone's famous. And when we look at all of those strains together, we see that each of them differ in different ways with respect to behaviors that look like things that we see in people with substance use disorders. How much do they explore their environment around them? How much reactivity do they have to certain stimuli and situations? Do they seek out novel environments? Do they prefer to hunker down and hide in the dark? What's their circadian cycle? Many people develop a substance use disorder in the art of managing an abnormal circadian rhythm. And then we see also different patterns in these different strains of mice, how much drug they will self-administer, at what rate do they acquire that self-administration, and if the drug is taken away, do they keep seeking it, or is it easy for them to stop seeking the drug? And so each of these measures, each of these colored lines here represents males and females from a different strain of mouse, and we can see that they differ in different ways. And when we can actually shuffle the genetic deck, we take these 8 strains of mice, breed them together in different ways, and we can then use those populations that come from that shuffling of that genetic material to connect specific genetic differences with specific behaviors and specific biological characteristics. Genes encode for proteins that might be receptors for neurotransmitters. They might be chemicals circulating that are manufactured by enzymes. All of these tiny differences affect the biology of the individuals. And we also know that there are places in the genome where an environmental event might alter to what extent other genes are expressed. So those life experiences change the patterns that our DNA uses. It's epigenetics. They change the patterns of gene expression throughout the brain and throughout the body. Now, we can actually bring together data from mice and humans in different ways, and when we do that, we can see that each of these strains of mice resembles people differently. And so when we look at genes expressed in people who had chronic cocaine use, we can see different strains of mice match to that pattern of people with chronic cocaine use in different ways. So different strains resemble the individuals, and some of them resemble them much better than others. We also see that in different strains of mice, there's a different risk for the lasting biological changes that occur in addiction circuitry. So here we're looking at 2 strains of mice. Both of them acquire cocaine self-administrations. We don't say the mice are using cocaine. We don't know if they're using it or not, but certainly they will learn to press a lever to take cocaine, and both strains will learn to do this. But if we turn off the cocaine, remove the drug, one strain of mouse restores the same pattern of gene expression that it had prior to exposure to the drug. But the other strain of mouse doesn't stop looking for the drug. And in that strain of mice, the genes that came up during learning the self-administration of the drug don't come back down. And so one of the things we might look for in terms of developing therapeutics is to say, is there something that we can do, even meditation, right? Even a behavioral intervention, even nutritional intervention, is there something that we can do to make the brain state resemble the state of the brain that can stop using the drug? When we look across mouse strains and many different behaviors, we can find the relationships among those behaviors. So we can ask the question, is preferring alcohol to water, is that correlated better with stress reactivity? Is it correlated with behavioral despair? Do mice that seek cocaine, are they more impulsive? Are they high novelty seeking? These are certainly things that we might speculate, but we can actually test which of these behaviors are related to one another. And when we look at a large population of mice, and we look at the behaviors that are associated with learning cocaine self-administration, extinguishing it, stop looking for the drug, and reinstating it, going back to seeking that drug in the presence of cues. In our case, some people look at stress. How does stress turn back on drug self-administration? We look at these different behaviors and we say, what background behaviors are also associated? And it turns out when we look at behaviors associated with impulsivity, we see that those are associated more with starting use and to some extent not extinguishing the use. But as we look at extinction and reinstatement, a relapse type behavior, but starting to seek the drug when you're faced with cues associated with the drug use, those are associated more with anxiety It was previously believed that in mice, and certainly in people, that it was those novelty seekers that are going out and looking for more drug, taking more drug, increasing their use. But there's also a component here that the anxiety potentially associated with not having the drug available anymore is an issue that for some individuals can make it more difficult to stop using. We can connect each of these different characteristics to different sets of genes and different biological pathways, and there we can start asking about questions about tailoring our approaches to individuals that have these different behaviors driving their substance use disorders. It's a long road from mouse genetics to these types of interventions, but we're on that road. Here we looked at human genetic studies of opioid use disorder, and we can see again the same point. Many of the genes associated with opioid use disorder in people are associated with lots of different biological and behavioral characteristics of mice. So it's not a one-size-fits-all solution. So when we get these thousands of genes associated with a human disease, we need to go back in and say, what is it that each of them do? And which of them are important to us? Which of them help us predict and treat that condition? We can use these data to actually identify which mouse strains best match any type of individual with the disorder. And so here we've done that. We've actually gone through the mouse populations. We did some data analyses that allow us to match those things. And we looked at other data that people had collected historically in different strains of mice. And we can actually see mice that were predicted to have low substance use disorder type characteristics, indeed will take less cocaine, respond less to novelty, decrease their exploration in a novel environment, less anxiety. And those that take more cocaine, or rather those that were predicted to more resemble people with the substance use disorders, also exhibit those characteristics. And we can, again, drill down to each individual gene and variant in one of these massive human genetic studies and go back in and use all of the data that's been collected in laboratory mice for nearly a century now and ask questions about what does each of those genes and variant do from the rich information here. So there's a compelling new drug that's in clinical trials around alcohol use disorder. It acts on an enzyme here. It's PDE4B is the word we use to call it, phosphodiesterase 4B. We can ask what that gene does, and when we look at the mouse behaviors across every different drug, there's hundreds of behaviors represented here, we see that that gene is involved mostly in withdrawal-related phenomena. So we say that this therapeutic might work best in alleviating the consequences of withdrawal and in that way reducing the amount of reuse, withdrawal-mediated use. So in summary, there's many, many differences in life experience, drug exposure history, and genetics. They come together in many different ways to shape an individual's addiction trajectory, and that's what we see when we look at the biology. Addiction histories and biology look very different in different individuals, and we can study these in mice and humans to understand, evaluate, and target interventions for addiction. A lot of people involved in all of the work that we do, and I'm especially grateful for the support of not just the Jackson Laboratory, but the NIH, NIDA, the National Institute on Drug Abuse, and the National Institute on Alcohol Abuse and Alcoholism, who have supported a couple of decades of our work on this topic. Thank you very much.
All right, thank you, Alyssa, for that excellent introduction to our topic and how overarching the Center for Addiction Biology at the Jackson Lab is covering, from one end to the other of addiction. I'm going to be focused on right now the risk associated with overdose. So overdose deaths, actually, we've made progress in the last few years. We've had decreases in overdoses because of the Narcan that's been distributed by many of these tables out here and many of these organizations. So thank you. This is a major success for human health and for public health in general. Opioids. So we know that they're great. If you have a surgery and you come out of surgery, you probably will need an opioid. It's really important for taking care of that pain, for the analgesia, but it also causes respiratory depression, cardiovascular depression, decreases your motility in your gut, constipation. Too much of an opioid causes sedation. If you get the right amount, you can get a euphoric approach as well as a urinary retention. So there's many aspects to the use of opioids. And as we know, there's been a history in the United States recently of an overprescription of opioids with the promise that they're not addictive when in fact they are very highly addictive. What happens during overdose? Opioid overdose generally results in death through what's called opioid-induced respiratory depression. So there's this region of the brain called the medulla. It's kind of in the brainstem area. There's a cluster of cells that contain opioid receptors. They respond to blood concentrations of oxygen and carbon dioxide and determine how fast or slow you should be breathing. Opioids bind to those receptors, and then they kind of mess up with the ability to regulate and respond appropriately. And so your respiratory rate can fall, and eventually death can result. And as I mentioned, Narcan or naloxone has been a great thing to discover, and its deployment in the United States has been amazing. Naloxone reverses overdose by displacing the actual opioid on the receptor. So in the little pink ball here is the opioid, like morphine or heroin. And then the naloxone comes on and kicks it off, and instead binds really tightly to the receptor. And the opioid goes away, and they no longer are experiencing the effect of the opioids. So their respirations come back, the euphoria goes away, withdrawal comes on if you were in chronic use. So it can be not pleasant to be revived by naloxone and Narcan if you've been a chronic user. Naloxone, however, in the advent of the newer synthetic opioids such as fentanyl and carfentanil, naloxone finds a difficulty in competing that opioid for the receptor. Fentanyl was designed to bind to the receptor really strongly, so naloxone finds it difficult to bind to it, and you may need to be re-narcanized. You may need to be repeated doses of Narcan to come through because of the potency of the opioids. All right, this slide is to show us that we are all very different. Notice the minifigs on the left; they're all very unique, but yet we're 99.9% similar. And a lot of these differences we can see at the level of outward appearance: red hair, green clothes, or brown hair, or whatever in these figures. But a lot of things that you can't see are your susceptibility to opioids. Some people, for example, the same dose that you use would actually be 100 times too much for them. Everybody has an individual susceptibility, and you can't see that by looking at their face. Just because they have the witch's hat on doesn't mean they're going to be super resistant, or the Batman cross mean they're going to be helmet mean they're going to be super sensitive. Now, we can't really do these experiments that I'm going to do about overdose sensitivity in humans. Instead, we're looking at mice. And mice, while not identical to humans, are 92% identical. So they have 92% similarity in genes. A lot of their arrangement is the same. The same region of same chunk of genes are arranged in the same order on a chromosome, a different number in mice, but it's the same arrangement in humans. So mice are a great tool. And just like the human population is very diverse, on the left here you can see we have a diverse mouse population that Alyssa showed us earlier called the diversity outbred population, where all the mice look very different. Their coat colors vary. Some are really cute. Some of them are all one color. Sometimes they have spots on them. This mouse population to each other is 99.9% similar, but there are differences besides the coat color. And if you look at the top two mice, those mice need to have a higher dose of opioid in order to have an effect. If you gave them just one capsule, they wouldn't feel it. They need like 100 capsules to feel the effect. Whereas that mouse down on the bottom, those white and black mice, a single dose or single capsule is enough. So that sensitivity, you can't really tell by looking at somebody what it's going to be. But if you look at the arrow pointing to the DNA, there are regions of the DNA that can tell us, that person's probably very susceptible to the use of opioids. They probably shouldn't use them that much, or their dosage needs to be monitored closely. So why are some mice or humans more sensitive than others? So on the top we have an NZO mouse. This is a mouse that one pill would be enough, and actually would be too much. About 50% of the mice of this type given one pill would die. But there's another strain, a black 6 mouse, that needs about 107 or 50 times as much opioid, in this case fentanyl, to have the same amount of population death. So what's happening? If you look in the figure on the left, the number of breaths, that sensitive mouse has a lower breath rate. It gets opioid just like this. So the red and the blue both are going to receive opioid after 15 minutes. You see a depression of respiratory effect, the frequency, and it continues over time. But the blue line starts out higher. It has a higher respiratory rate, and then it drops. But if you look at the volume, the amount that the mice are exhaling, if you look at the depth of the breath in the bottom left, those mice that are most sensitive actually take larger breaths, and then when given fentanyl, actually increase the depth of their breath instead of decreasing the depth of their breath. So you would think they might actually be more resistant, but in fact, it's counterintuitive. Those mice are more sensitive to opioids. And you can see correspondingly the oxygenation of the blood. The blue figure line shows the more resistant strain of mice has higher oxygenation, and then the more sensitive strain, the red, has lower oxygenation associated with the effects of the opioid-induced respiratory depression. So the blood is not getting the oxygen from the breathing. So naloxone and Narcan are great, as I've said, but that re-narcanization, the needing repeated doses, can be a problem. So is there another way that we can stimulate breathing through other respiratory control centers within the brain? Can we, stimulate a respiratory uptake in addition to trying to replace the opioid at the receptor? And so that's pushing us towards these other ideas of naloxone plus a respiratory stimulant or an adjuvant. So here the idea is when you're given naloxone, you're also given another compound. And we've identified some of these compounds in our studies with mice using data from humans. We started with, got to mice, identified a compound, and then if we give that compound to you when we give you Narcan, as the Narcan and naloxone wears off, this compound is going to take off and it's going to increase your breathing rate on its own. So it's like a 1-2 punch. The one punch would be the naloxone affecting the opioid receptor, and then the second would be that secondary compound, which is going to help stimulate the respiratory depression. And so this is the type of finding that we've had in the last 5 years of working at the Jackson Laboratory on opioid-induced respiratory depression, is identifying these possible new things that we can test for therapeutic advancement in the clinic to help with these other drugs like nitazines as well that are hitting the street, and carfentanil. So the takeaways, a key thing that I didn't mention, but that is key, is that addiction is a disease. It has a biological basis. It's not a moral failing. It is a chronic brain disease. Opioid overdose is a biological mechanism, and each person has their own risk potential. Genetic variation in a population can help us identify new targets, things that we hadn't thought of to look at for new reversal agents to combat the current and the emerging threats, the different drugs that are coming out. And model organisms give us the ability to try and separate the different functions of the opioids. Is the opioid working at the level of gas exchange? Is it working at the level of respiratory rate? What level of mechanism is the opioid working with the genetic variation? And none of this is done alone. As Alyssa said, there's quite a large team and funding from the NIH that supports us, and a group of lots of collaborators and talented people at JAX who facilitate. Thank you.
All right, I'm going to wrap us up. I'm going to talk to us today about my work at the Jackson Laboratory as a postdoctoral associate in Vivek Kumar's lab, trying to understand the genetic modifiers of opioid withdrawal. And really my work is asking the question, are we studying complex behaviors across genetics in the right way, and how can we improve the models that we use to more appropriately interrogate the things we care about in humans when we go to treat them. So we've talked about this a lot, but opioid use disorder is this compulsive recurring cycle of drug taking, intoxication, withdrawal, and then anticipation and preoccupation with finding more drug. And that's kind of displayed in this very academic and simplified figure that's excluding social and economic and other sort of environmental factors. But the reason I'm really interested in withdrawal is because it provides one of the first barriers to recovery. Withdrawal drives people, patients, to seek more opioids and consume more opioids. And we know that alleviating withdrawal helps patients because there are FDA-approved medications that we can use to blunt the severity of withdrawal and improve patient outcomes. But there are only one or two medications, and they work through the same pathway, the same biological pathways. And as you can see, withdrawal is not mediated by just a single pathway. There's no one single lever that we can push on to change withdrawal. There's many different opportunities. And so I think that means that there are more opportunities that we're not taking advantage of to help people overcome that initial stage of withdrawal and enter treatment and hopefully improve their outcomes. So that's why I study withdrawal in opioid use disorder. Why do I study addiction? Genetics. We know that genetics influences a person's risk to developing opioid addiction. And we know that in a few ways in humans. There are twin studies that Alyssa was talking about that demonstrate that there's heritability by comparing identical twins. And while the estimates vary, it clearly demonstrates that a portion of your risk for developing opioid use disorder is attributable to your genetics. And then we can also take an approach called the genome-wide association study, where we take lots and lots of people, like 23andMe data, and we see what specific changes in a DNA sequence across a lot of people puts you at more risk for opioid use disorder. And by doing this, we've demonstrated specific genetic regions and genetic variants that we think are specifically contributing. And the hope is, right, that if we understand the genetics of addiction, it'll help us understand the biology of addiction. And by understanding the biology of addiction, we can design new treatments and therapeutics to help treat opioid addiction. So that's why I study withdrawal. That's why we study genetics in the context of opioid use disorder and withdrawal. So why mice? And it's because mice are excellent models of addiction. I'm using some loose language here, but mice exhibit a lot of the same behaviors that humans do when they're exposed to opioids, right? Mice work for opioids. They develop tolerance to opioids. They experience withdrawal when they stop receiving opioids. And that face validity really helps us be confident that mice are good models to study opioid addiction. Additionally, mice share a lot of the same anatomy, the neuroanatomy that mediates addiction in humans, meaning that when we find mechanisms in mice, we can be confident that there is probably an analog neuroanatomically in humans. And then mice also allow us to model this complex emergent phenomena that is addiction, right? So this is something that would be very hard to study in cells in a dish or using a simulation, because there's a lot of factors, like Alyssa discussed earlier, that contribute to the development and the sustainment of opioid use disorder and addiction-like behaviors. And then finally, we know that genetics, like humans, has an impact on addiction behaviors in mice, and the genetic variation modifies that sort of response to opioids. So with all of that, let's talk really briefly about how we study addiction through genetics in mice. And I think we largely do it in two ways. We can take advantage of the natural variation in genetics across mice. So we have these strains of mice that are represented by these little bars. And within each strain, right, within the AJs, for example, the mice are genetically identical. But across strains, they're genetically distinct, right? And so we can compare the way that those mice respond to opioids and then work backwards to try to understand how the genetics are mediating that change. We can also go within a single strain And we can take a specific genetic element and we can use genetic engineering to remove it or delete it or change it, and we can see how that specific strain or that specific change on an otherwise genetically identical genetic background changes opioid responses. So that leads us to kind of this sort of central workflow that we've got, this central hypothesis where genetic variation is leading to some dysfunction within a cell that changes the way the cell behaves. That cell changes the way that its neighbors behave. And from that sort of circuit or brain-wide dysregulation, it changes the psychological experience an animal, which is to say a human or a mouse experiences, and that changes behavior of the animal, be it a mouse or a human, right? And so what we try to do is link these genetic variants to changes in behavior and then work inward to this point where we think novel therapeutics live, right? These specific proteins or transcripts that we're looking at. And with things like self-administration, that's really nice because the behavior that we're looking at, we trust to model the behavior that we care about in humans, which is how much are they willing to work or go out and seek a drug. But withdrawal is trickier because withdrawal is sitting in this altered latent state, this altered emotional state. We care about how unpleasant opioid withdrawal is, and we predict how unpleasant that is with how the mouse behaves. Because unlike humans, we can't ask them to self-report their discomfort. And so if we try to study opioid withdrawal across genetics, we run into this fundamental problem, which is this arrow, is this relationship between discomfort and behavior the same across genetic diversity, or is it dynamic? And if it is dynamic, how do we compare across genetic diversity and actually start to understand how genetic variants affect this sort of discomfort state? So the way we traditionally do this in mice is we use single measures. We put mice in these mazes and we see how much time they spend in an exposed or enclosed arm, or we put them in an arena and we see how much they jump. We record single behaviors. There's other ways, but these are sort of examples. And I think you can intuit that this is inherently a limiting approach. It's like looking through a keyhole and trying to see what's in the room beyond it. You've only got a certain amount of view of resolution into, again, that discomfort that you're interested in opioid withdrawal. And this is not how we do it in humans, right? We use these clinical opioid withdrawal scores, cows, and there's 11 items. And I think you can intuit that if you just limited yourself to one item, you might be able to choose a good item to predict somebody's withdrawal, like anxiety or perhaps restlessness, but you're still inherently limiting the amount of information you can understand by going from 11 to 1. So the way that we try to overcome this in the lab that I work in is we use these sophisticated computer vision AI approaches to get more information about how a mouse behaves. So we put an animal who's experiencing withdrawal or not in this arena, and we allow it to move. And as we allow it to sort of voluntarily express its behavior, we overlay these points on the mouse. And by understanding how these points change over time and in relationship to each other, we can infer what the mouse is doing. And by doing this, we can go from simple measures like distance traveled and how much time it spends in the edges to a really rich index of behaviors that more appropriately captures the entirety of the mouse's sort of expressed behavior in response to withdrawal. So the central question then is how does opioid withdrawal differ across genetics if it does differ across genetics? And to answer that question by applying those techniques, we're going to use these star players. We're going to use these genetically diverse 9 strains of mice that are, again, identical to each other within a strain, but diverse across a strain. We're going to have them experience opioid withdrawal, and we're going to see how their behavior changes. And this is a busy slide, but what I want you to know is each bar is a strain of mice. And the bar that goes above 0 means it increases in response to withdrawal, and a bar that goes below 0 means it decreases in response to withdrawal. And I think you can kind of take away from this slide that if you chose one of these behaviors and you ordered the severity of withdrawal in these mice based on those behaviors, you would end up with 6 different orders. And that's fundamentally the problem that I think we're facing. So the fact that they're different doesn't necessarily mean that we can detect withdrawal. That's another thing that we're really interested in. So if we take all of these behaviors and we do a statistical test and we kind of cram all 600 features that I get into an XY plane, right? We would hope that we would find all of the withdrawal mice in one area and all of the naive mice in the other, right? And that would help us be confident that we can identify withdrawal across genetic diversity, even if it looks different across genetic diversity. And that's exactly what we see here. So this is a little overwhelming perhaps, but the red dots are mice that are experiencing withdrawal for each of these 9 strains, and the blue ones are mice that are not. They're just at baseline. They've been administered a control substance. And you can see in all 9 of these, we get a group of red dots and a group of blue dots, which gives us confidence that we can actually resolve withdrawal. What's exciting is when we combine all the mice together, we also get this shared component, this shared clustering that seems to work across all of the genetic diversity that we've tested here. Which means that excitingly, there is some shared behavioral component in the way these mice express withdrawal, and that might help us compare withdrawal severity across genetics. So the reason this matters is I think that this tool and these approaches are going to help us move away from single reductionist ways of studying opioid withdrawal that might be missing what's most important to patient populations. And by expanding into this really rich behavioral index, we improve our ability to help patients by better studying withdrawal. We can study that, we can improve the way that we study withdrawal across genetic diversity, like I just said, but we can also build really sensitive ways of testing withdrawal in individual genetic backgrounds and use that to screen novel therapeutics or look at the effects of genetic deletions across a wider selection of genetic diversity, which will give us more confidence again that what we find will work in genetically diverse humans. Yeah, thank you for your attention.
All right, thank you, Jake. Thank you to our other speakers. We now have a few minutes for questions, and I'd again invite you to go to Slido and provide your question there. I'll keep an eye on that window while I have a few other questions that I would like to ask the panel. We'll get us started. So each of you talked about genetic diversity, you talked about individual genetics, individual variation, and I think we're seeing in other, particularly cancer, I think about the Maine Cancer Genomics Initiative, which is another JAX program that really focuses on individual genetics of cancer patients and tying them with clinical trials and treatments that are specific to them. We are seeing a range of understanding of precision medicine. So could one, and Jake, maybe I'd challenge you to take the first crack at this answer. How does precision medicine, or how do you think precision medicine might begin to inform withdrawal treatments or approaching a withdrawal treatment in an individual patient?
Sure. So I think that there's 2 ways precision medicine can help in this field. And the first is the actual prescription of opioids and what pain management medication is prescribed to patients to reduce the risk of transition to sort of dependence and entering withdrawal. But the other way is, we've talked about how there's genetic variation that puts or predisposes you to addiction risk. You can kind of think of the brain as a bunch of knobs and dials, and as you turn one up, you might predispose, someone to addiction, and understanding where those pressures are within an individual patient may help us treat that patient better. I think to do that, though, we need a bigger toolkit to help treat opioid withdrawal, right? When you only have one medication and it works through the same way, it's very hard to apply precision medicine approaches. And so things that Alyssa and Jason are doing, they're trying to better describe the risk of addiction genetically are really helpful in achieving that sort of precision medicine approach in the future.
Okay, thank you. Jason, moving on to you, I have a question about the naloxone plus respiratory stimulant strategy. I'm curious, how close are we to a next generation reversal approach that utilizes what you just described?
I think that we're closer than we've been at the Jackson Lab. I've actually put in a patent disclosure indicating that I have a compound and I have like a year to really bolster my support for this disclosure. So I'm really excited that maybe there is a additive that we can add that can help prevent that renarcanization, where people can just get that one shot of naloxone plus or Narcan plus, and it take them through, and they don't need the multiple hits. So I think that in the past 5 or 6 years, thanks to my funding from the NIH, I've been able to actually move my program quite a bit forward.
That's great, very exciting. Looking forward to more reports on that in the future. Okay, some questions have definitely come in from the audience, so I'm going to take a look at these. And this is an interesting one. How do GLP-1 compounds figure into research? Alyssa?
So we haven't done any work yet with GLP-1, but they are showing a lot of great promise, just from people who've been using them for weight loss and type 2 diabetes. Many people report that has reduced their alcohol use and other drugs. So they are the subject of a lot of new research, and I think they're quite promising for some people, right? Everything will work differently for different people. Some of our work we've identified in mice is that there's definitely a biology of responding to the perception of scarcity and satisfying of that need. And so drugs that are working on the circuitry of hunger and satiety might be tapping into the same circuitry. GLP-1 may not be getting at the root cause of that change. We talked a little bit about epigenetics. What is it that switches on when people are faced with a lack of resources in their environment? And in some people, is that switch on naturally at birth? They are basically born in a condition of sensing that they don't have enough resources, or sensing that they don't have enough, even when they are in an abundant society or in an abundant socioeconomic status. That perception of need feeds the desire to use. So having drugs that work on those types of mechanisms is going to be an important direction in the future for sure.
Great, thank you. Sticking with the question of epigenetics, a question came in. Does anyone have thoughts? And I will connect this back to a prior panel we did several years ago and mention the work of Jennifer Honeycutt from Bowdoin College. So anyway, the question is, are there thoughts on trauma and early life adversity and the role of those things, and how it influences genetics and susceptibility for addiction? Is there a biological basis originating in trauma or early life adversity?
Absolutely. There's a number of different consequences. Chronic unpredictable stress and the number of adverse childhood experiences certainly influences many different things that play into a substance use disorder. So one thing that we see in people with chronic trauma exposure is changes in their executive function, changes in behavioral inhibition, changes in organization, and many things that are necessary skills for successful recovery. So those same executive functions, those frontal lobe functions, are affected by different drugs. So adolescents using cannabis have lasting effects on executive functions that may make it more difficult for them to change their addiction-related behaviors in the future. There's also effects of that chronic stress on stress reactivity, so how those individuals respond to future stressors. And potentially, again, how does stress and threat influence the extent to which individuals are activated to seek resources? And let's say drugs drugs, rewarding drugs are those resources, and that reward may come from the relief of pain, the relief of stress, and the relief of anxiety, or it may be actually a pleasurable stimulus. So all of those life experiences do alter the biology, and they do predispose individuals to other behaviors that may impact either the extent to which they use substances, the extent to which they maintain that use, and then what challenges they might experience throughout their recovery.
Great. Thank you, Alyssa. And again, just to mention Jennifer Honeycutt, Bowdoin College, for more specifically on adverse childhood events. Let's see. So the speaker has alluded to a future where clinicians can personalize care and take into account a predisposition for dependence. What would that look like? The follow-up question, universal genetic testing for everybody or something else? How far are we from that in practice? Jason takes the bait.
All right. I think pharmacogenomics is an emerging field that's been shown to be very effective for certain conditions. For example, warfarin, a blood thinner, you can predict based on your genotype or your genetics how sensitive you're going to be and how frequently you're going to have to do have your blood work done to see how the warfarin is working, or Coumadin is another name for it. How close are we to this? I think psychological medicines really could benefit from this in the future, because there are many paths to Rome. There are many ways that you can have major depressive disorder. If we can find some ways to separate the treatment paradigms, because there are some that are responsive to SSRIs and there are some that are not. If we can associate that pre-existing genetic mutation with an effect that works, or meditation or yoga works for this particular genetic setup, then I think that would really move things forward. How close are we? Yeah, there's lots of issues with privacy and insurance and all those things.
We don't yet know, Alyssa.
Yeah, I would say, and the complexity of the situation. Not to say that it's hopelessly complex, but we are talking about something that's far more complex than individual enzymes and their effects on blood thinners. So it's I'd say we're not there yet. Single genetic tests or even a whole genome isn't going to precisely predict an individual's addiction risk. And so we have to consider all of the information that we have about people. And look, many people know about their own family history, and that's a good indicator of risk. And then the question becomes, what do you do with that family history? Is that family history confining, or is that family history suggesting a different set of behaviors? And even knowing that family history, is it even something for some individuals that they can willfully overcome, or is it just something that might bring them closer to an awareness of what is actually going on in their own personal experience, because they've had the opportunity to see different family members? So there's a lot of complexity there, and that individual experience doesn't necessarily require genetic tests, but certainly we learn a lot from looking at the biology of populations as a whole.
Thanks. One of the really neat programs we do at the Jackson Laboratory is a high school-based program. We're in about 70% of the high schools in Maine, and we're teaching Maine high school students these concepts in genetics and genomics. And it's not just the science, it's the topics that Alyssa and our other panelists have just covered. Yes, you might have access to the information, but what can you do with it? What choices do you have with respect to your genetic information, or the genetic information that might be opened up to you if a family member receives a genetic test? So it's really a holistic approach about learning the science, but then also, how do you wrestle with it from a social point of view? So just a quick plug on that one. Great questions coming in. Let's see. Somebody asks, is there a way to witness this research in person or by video? Very fascinating, would love to learn more. So delighted this has sparked an interest in at least one person, so thank you for that. I will say that in my role, one of the things that I do is I welcome groups to the Jackson Laboratory on a very regular basis. We, for example, host a program of the Maine Development Foundation every year, Leadership Maine. Some of you may know about it. We host groups of teachers who come into the Jackson Laboratory through another program run by Maine nonprofit Educate Maine. We welcome chambers of commerce. Anyway, we don't have an open door policy because it is a laboratory, and there are restrictions that we have in place, as well as a working environment where fantastic hard questions can be asked and answered. But if somebody or a group, or you're part of a group that would like to have a focused on-site discussion about this, please reach out to me, and I can help put those pieces together. So I think we'll end because with one more question for each of you, and the hopeful sign is a lit, and that is one of the themes of today's session. So I'd like to ask, starting with Jake first, what makes you most hopeful? This is a question from the audience. What makes you most hopeful about the work you are doing, and do you foresee a future where genetic therapies could act as in a preventative way to combat addiction? And we'll just ask each panelist to share their hopeful thoughts for the next 5 to 8 years.
I am quite hopeful. I think there's a lot of opportunity for improvement, and that's where the hope comes from. I think that in the laboratory, we see a lot of these differences in animals, and it's a lot of, again, opportunity that we have in the face of adversity. Does that come in the form of, informed pharmacotherapy or genetic therapy? I think probably more on the pharmacotherapy side, at least in the near future. But no, I'm immensely hopeful.
Thanks. Jason?
Yeah, I think the biggest leap forward is the effect that biological research on addiction has had for helping to reduce stigma. So stigma of addiction and being a personal choice or a willpower issue is a big problem, and people need to realize that there is a biological basis for the way that things are occurring, and that there are interventions. There's medical assisted therapies, but there's just like a very high stigma. There's several medications that are out there for treatment of alcohol use disorder, but only 2% of people get medication for alcohol use disorder, whereas diabetes, 85% of the people get treatment for diabetes. So that stigma speaks to its the disease and its lack of people getting it treated. So the more people understand, like my 85-year-old father finally gets it, I think that it's a biological thing, it's a disease, it's not somebody not going to church on Sunday.
I think for me, I'm learning so much more, and we all as a field are learning so much more about the interplay between sleep, exercise, life experience, adolescent drug use, and how that plays into future substance use disorders. And so the more we learn about mental health and addiction, and the more that we can come in at the ground floor and address those basic mental health and developmental issues, the better chance we have at reducing the impacts of a full-blown substance use disorder. And so I think that to me is the thing that we're learning the most. The way we've approached biological research in the past has really been to cut up the problem into lots of separate little pieces. And so in many cases, people would try to study mental health and substance use disorders in some sort of artificially purified way. And the more that we understand the interrelationships among these things, the better shot we have at modeling and intervening on the whole trajectory and potentially preventing people from getting to the state that becomes increasingly intractable.
Great. Thank you very much. I want to close just by offering to thank one individual and one group. The group is, of course, our panel. I want to thank you for your curiosity, your scientific drive, your kind of relentless asking of questions to get at these answers that we don't yet know. And I also want to thank you for always grounding the work that you do in the needs of the community and the needs of individual people. So thank you for that. Thank you for joining us today. The second thank you is for Gordon Smith. He's being thanked properly a lot today, and I don't know if he's in this room, but Gordon has personally been invested, curious, an advocate for the research at the Jackson Laboratory, including welcoming us to this panel on a recurring basis and giving us really a prominent stage for which to share the work that we do. So thank you, Gordon, for that. Thank the panel, and thank you all.
So again, they really need no introduction. They were with us in the same role in 2019. And the first summit that we had at the Augusta Civic Center, it was so meaningful then, and that we invited them back to be part of our first summit and our 8th summit. So without further ado, Shelley and David Yankowski.
Hello. Thank you for quieting down. I had other tricks up my sleeve, but I won't bring them out now. I'm Shelley, and this is my husband, Dave, and we have a story of how opioid use disorder affected our family. Helpless, hopeless, grief, shame, overwhelmed, hurt. We felt all of this and a lot more when our sons started using drugs. We didn't talk about it. We didn't want anybody to know about it. We were ashamed and embarrassed about it, and we enabled them. We paid rent, car payments, insurance payments, bought gas and groceries. We gave them money to make it go away. We didn't take care of ourselves. We didn't go to the dentist. We stopped going to the doctor. We didn't want to hear them ask us how the boys are doing. We didn't have a good answer. We lived each day in fear that they would die or crash their car and it would be exposed. We stopped hanging out with our friends. We avoided family gatherings. Again, we didn't want to answer those questions of how the boys are doing. Where are they? We didn't have to, we lied to ourselves and to others about it. We walked on eggshells and went around putting out little fires. And we did everything we could to make sure that our grandchildren were safe. We were lied to, stolen from, yelled at, belittled, pushed around. We were told we couldn't get to see our grandkids if we didn't give some money. They took our debit cards with permission to take out $20 or $40. And when I checked my online account, they had taken $200 and $300, money we didn't have in there. Those were not the boys we raised. Those are what became of our boys when they started using drugs. It started with marijuana, progressed to Percocet, oxycodone, heroin, cocaine, and fentanyl. When Adam overdosed the first time, we already knew we had a problem. We spent our days and nights worrying about him and our grandchildren. Dave being a state trooper, and myself at the time I was a dispatcher, it made us all too familiar with overdoses, Narcan, and death. But never in our life would we have thought it would happen to us with our own children. Our children were supposed to know better. They'd been taught right from wrong. They'd been taught to be kind to others. They had been shown drugs and paraphernalia and told to stay away from the people who used them. Each of them knew to be his own person. They were both brave and smart, and they were so funny. Adam and Sean were our sons, and we loved them unconditionally. Adam died twice in the same week. He died August 1, 2017, when Narcan was administered twice by Bangor PD. He was brought to the hospital and released. In a matter of 3 hours, from death to life, he was back home. We wanted him to get help. We begged him to get help, And he kept saying he didn't need our help. He didn't need help. He said he'd quit on his own several times before and he could do it again. He didn't want us to interfere. 8 years ago, resources were very limited compared to today. The rest of the week, I was in training at the Maine Criminal Justice Academy, and that left Dave to pick up the pieces at home. It was a long week, but without Narcan, we would not have had that extra week with Adam. On Sunday night, I was in bed and I could hear him in the kitchen. I went to the bathroom and he asked me if he was being too loud. Then he said, "Mom, I know this week has been rough and I'm sorry. I will be better. I love you." I told him I loved him too, and we hugged for the last time ever. On August 7, 2017, the next morning, I found my son Adam dead on the floor in his bedroom. I kept telling Dave we had to do something, and he kept saying there was nothing we could do. My son was dead again, and this time it was forever. Adam and our youngest son, Sean, were best friends. One never did something without the other. Throughout their lives, I'd been known to say, "Listen, you guys only have each other when we are gone, so you better figure out how to get along." 10 months after Adam died, on the morning of June 23, 2018, Sean had gotten a flat tire and stayed at a friend's house Friday night. There was a knock on the door, and the dogs ran towards it, barking. Dave headed to the door and said, "Friggin' Sean, probably forgot his house key." Dave came back 2 seconds later and said, "Shell, something has happened to Sean, and they are here to tell us." Dave had made many death notifications to others and could tell from the lieutenant's face and my boss's face that things were not good. And our priest was there. It's never going to end well when the priest is there. They told us Sean had overdosed and died at his friend's house. We couldn't believe what we were hearing. We had told Sean we couldn't lose another son to overdose. I collapsed on my couch crying, and when I looked up, the lieutenant, my boss, and the priest were all crying too. They had done their duty to come tell us that our only son we had left was dead. They knew as they pulled into our driveway that knocking on our door would change our lives forever again. We went to the funeral home that afternoon. It was kind of like deja vu, reliving the single worst moment in our life over again. I hadn't been able to see Sean to say goodbye to him the way that I'd been able to say goodbye to Adam on his bedroom floor. They laid him in a room for me to go in and see him. He looked so peaceful, like he was sleeping, and he had his glasses on, which was surreal for me because he always fell asleep with his glasses on. I heard him saying in my head, as he'd said many times after Adam passed, "Mom, I didn't just lose my brother, I lost my best friend." I hugged him, I told him I loved him, and I said goodbye. When both of your kids die, it's hard to breathe. Your insides are sucked out of your body. Your heart physically hurts. And much like Dorothy in The Wizard of Oz, where the world was spinning around her, you can't make it stop. It just goes around you. And you cry until there are no tears left, and then you cry some more. We were angry with God. We were broken. We still are. It's not easy to stand up here in front of you and tell you about Adam and Sean. It's hard for us to admit that we didn't know what to do for them. However, we stand here today and we speak about our sons' lives because it's time it gets spoken about. We were too ashamed and too embarrassed to let people know what we were going through. We must fight the stigma. Just say the words. Dave and I started speaking to anyone who would listen about our sons. We knew it was time to speak about it. No more hiding from it. We wanted people to be able to talk about their struggles with us, with their loved ones, and with their friends. I'm sorry. We didn't want anyone else to have to go through what we've been going through. with the boys, and hiding from it didn't help anyone. If you have a person in your life who suffers from substance use disorder, there are 3 things we want to leave with you today. Things we wished we had done. Number one is don't enable them. It's one of the hardest things you'll ever do in your life, but you can't be the one that's always bailing them out of the hard spots. You can't give them money. They're going to buy drugs with it. But they must fall, and the only thing getting themselves back up is themselves. There are ways to help them without funding their drug habit with cash. We would go to the gas station and use our card for them to pump the gas. We'd go to the grocery store to buy them groceries and bring it to them. The other thing is number 2, plant seeds. Let them know that when they are ready to get better, you are there for them. Be open and upfront with them. Tell them you know they are struggling and you want to help them when they want to get better. Your rock bottom will come way before theirs. Watching them suffer is hard. When they are at their lowest and ready for help, they will know who they can count on to reach down and lift them up. Number 3 is love them unconditionally. Let them know that no matter what, you will always love them. They're going to mess things up a lot. Love them anyway. Tell them every chance you get that you love them, because there may be a day that you can't tell them that anymore. Many people have said to us, you will find your new normal. The word normal has always made me cringe. There's nothing normal about losing both of your kids. And what's a normal life anymore for us? We used to be sad and then it was okay. Now we're sad all day. Is that our new normal? I Googled some words instead of new normal and I found one I really like. Maybe you'll use it next time you talk to someone. But I liked adjusted reality. You'll find your adjusted reality. Because it's your reality. It's what you are now. That's what we are. We're the people that lost both their sons. And that's okay. It's an adjusted reality. The one statement we have heard more than any other since Adam and Sean died is, I don't know how you do it. Newsflash, we don't know how we do it either. In the early years after their deaths, we were debilitated. Every single thing we did was hard. Breathing, sleeping, walking, it all hurt us inside. But you pick yourself up, you dust yourself off, you check to see if everything still works, and then you take one step after the other, walking out of that dumpster fire that your life has become. We knew if we didn't go out and talk about the boys wherever anyone would let us, then the boys died in vain. No one was saying their names. Their lives were meaningless. The stigma needs to stop. Talk about it. Say the words. We found that there are so many people living the lives that we lived for the 5 years that they suffered from substance use disorder, waiting for the phone to ring, waiting for the police to call, waiting to find your son dead or your daughter dead. We also found out that there are multitudes of people who have lost loved ones to this disease. To think that this crisis isn't touching everyone in some way is like sticking your head in the sand and pretending it's wonderful everywhere. It's not. Drugs kill the pain, but they also kill the joy, and the hope, and the body, and the mind, and finally, the soul. They kill all of that for the person struggling with opioid use disorder, as well as their family, friends, and anyone that knows them. Maya Angelou said, I did then what I knew how to do. Now that I know better, I do better. You are here today to remember our lost loved ones and to support the ones in recovery and have compassion for those in the throes of addiction. Educate yourself in substance use disorder and the difficult journey to recovery. When you leave here today, share what you've learned from us. Talk about it. Say the words. Fight the stigma. Be a recovery ally and fight with them. Our sons weren't the drugs. They were our boys. They were a father and an uncle. They were grandsons. We lost sight of that several times throughout the 5 years that we struggled with them. And it's important as human beings that you don't lose sight of that ever. They are people. They are your people. They are all our people. Thank you.
Thank you. Thank you, Shelley and David, for sharing your story as hard as it is. I want to make just a couple introductions before introducing our next speaker, the best Medicaid director in the United States of America, Michelle Probert. But first, I want to introduce 5 people that are here from the cabinet. We have a recovery cabinet that we consider all the commissioners to be part of this work, and they all are part of the work. But 5 of them are here today and really involved with us every day, and I'm so appreciative of that. So I'm just going to introduce them all together, have them stand and thank them for being there, supporting this work every day. The first is our own Commissioner of Health and Human Services, Sarah Gagne-Holmes. She's going to be introducing the governor in a moment as well. Commissioner Michael Soschuk from the Department of Public Safety. We give him a number of tasks, so he may be somewhere in this, in this building protecting the governor. We think that Commissioner Liberty is here, Randy is here. I've not seen him, but he was expecting to be here. And if you haven't read Randy's book, Liberty's Prison, it's a very special story. And you might have heard it on National Public Radio or have seen him on 207. It's a very special story. Joan Cohen, our Commissioner of Professional Financial Regulation. Joan, thank you for being here and supporting our work. And Elaine Clark, who is the Acting Commissioner of the Department of Administrative and Financial Services. So would you all stand and accept our thanks for what you do every day with us. And now it's my pleasure to introduce Michelle Probert, our state's Medicaid director. Executive Order 1 in January of 2019, has made it possible by expanding Medicaid for well over 100,000 people to have coverage. I think some 33,000 of those individuals have filed claims for substance use disorder. It is probably the most impactful thing that the governor has done. And we want to protect all of that. Michelle's going to talk to us about that. She had an opportunity to speak with us last year from Augusta, and Michelle, we are so glad to have you back, and I'm so glad to have you in such a partner in this work. Thank you.
Thank you, Gordon, and good morning, everyone. I think they said, Michelle talks a lot sometimes, so maybe we should put her right in front of the governor because there's nothing like an incentive to try to be on time when you know the governor is speaking after you. So good idea, Gordon. All right, so again, my name is Michelle Probert. I am the director for MaineCare, which is Maine's Medicaid program. And we would not be where we are in the state of Maine today with recovery from substance use disorder without MaineCare. I want folks who work at the Office of MaineCare Services to stand up for a moment. I see Courtney Pladsen, our medical director, down here. I know you're out there, but let's give all of those folks a round of applause. Our Maine Care team listens and responds. They seek progress at every opportunity, and they lead with compassion and optimism, and I am grateful for them every day. So Maine Care coverage means treatment. And treatment means recovery. 385,000 Mainers receive their health insurance through Maine Care. That is by far the biggest source of health insurance in the state. And the services that are listed on this slide are available to about 40,000 of these members who have a substance use disorder. We focus on innovative models that look at a team-based approach with peer recovery coaches. We have our Maine Mom program, opioid health homes, certified community behavioral health clinics, and all of this work is to recognize that the individuals that we serve are whole people, they are part of communities, and they require medical services, behavioral health services, as well as social supports. So unfortunately, today I'm going to focus on the fact that our coverage is under threat. And when Maine Care coverage is under threat, that means individuals' ability to recover from SUD in the state of Maine is also under threat. I'm going to focus today on work requirements that are forthcoming after federal legislation was passed about a year ago. But I don't want us to be depressed, although it can be a little depressing. This is really a call to action. I am excited, I'm always excited to come to this conference because it's such a great mix of folks from different areas. We've got members, we've got affected others, we've got peers, we've got providers, we've got people who work for the state. And it is the people in this room and your networks who can swing the needle on making sure that we are able to maintain access to the greatest extent possible to treatment for everybody, and especially for folks with substance use disorder. We need your help. We have Congress and the courts who are going to decide federal policy. The state of Maine, we are working as hard as we can to make sure that we can access data to make sure people keep their coverage. And that leaves you. You are best positioned to make sure that Maine Care members and people who are applying for Maine Care know about the requirements, stay in touch to maintain their coverage. All right, so these are a few of the requirements that passed about a year ago that are going to start going into effect this fall and then this January. I only have time to talk about the work requirements, but I encourage you to look at these other changes as well because they have very real and sometimes scary impacts for our fellow Mainers. So what are work requirements? First, I will note that work requirements just impact what we call our Maine Care expansion or Medicaid expansion population. That's about 20%, so 1 in 5 of the 385,000 Mainers who are covered under Maine Care that I referenced earlier. What are work requirements? They start in January. They only apply when somebody goes in to apply for Maine Care for the first goes in to apply for Maine Care or when they have to renew. And people are going to need to demonstrate that they have at least $580 in income from work in a month, or that they've spent 80 hours volunteering, or they've been in school half-time. Or, and this is very important, that they meet an exception so they don't have to meet those work or volunteer requirements. So that is what is going to start rolling out over the course of the year, starting in January. All right, so that is what work requirements are. Again, some of the biggest threats to people losing coverage, it's not even necessarily being able to meet the requirement or in its exception. That's most people don't know that this is going to be happening. And so that's where you come in, is outreach and education and making sure that people are aware. And then secondly, when people hear work requirements, they think, oh my gosh, this applies to everybody and I can't do that, so I'm not even going to apply because I won't get it, or I'm not going to try to renew. And that's the second big threat that we need to make sure through outreach and education, people are well informed and educated so that people can maintain their coverage. So this is just a partial list of individuals who do not need to meet work requirements. So once again, we're talking about our main care expansion population. It's about 1 in 5. Individuals who do not need to meet work requirements, anybody under age 19 or over age 64, parents who have children under the age of 14, American Indians and Alaska Natives, people who are disabled veterans, people who have been released from a correctional facility within the past 3 months, or are pregnant, or who meet certain medical criteria. I'm going to flag this red box because unfortunately there's still a lot of uncertainty at the federal level around how people can get a medical exception. This is an issue that is in the courts right now. Maine is one of 26 states that are part of a lawsuit because the federal rule on work requirements that was issued very recently is more restrictive than the statute that Congress passed. And so we are fighting at the same time that we are working to be able to implement. Regardless of the details, and we will be communicating as soon as we have more certainty, I do want everyone to know that substance use disorder is called out in statute as something that states have to consider in order to grant medical exceptions to people. So if you have a substance use disorder, the intention is that you would be accepted from work requirements. The question that is out there right now is, do you need to demonstrate anything else? And that's what we're working to get clarity on from the federal government. However, regardless of those details, we do know some things. For individuals who have a substance use disorder and need help, if they don't already have Maine Care, make sure that they apply for Maine Care this year before these requirements go into effect. Also, make sure that they get a diagnosis on record. This is basically to say, get help from a professional so the state knows, say through our Maine Care claims, that someone has a substance use disorder, and then we can make sure that they can stay enrolled. And lastly, friends, families, peers, providers, rally around members to keep their contact info up to date, to check their mail and their email, and to add the Office for Family Independence that does our Maine Care and TANF and food stamp, SNAP applications to their contacts. If we can't stay in touch with people, then people lose their coverage. And that is something that all of us have the ability to be able to help with. So that is the depressing part of my presentation, but again, I hope that people really see this as a call to action, and I do want you all to know that hope and progress continue. We have an application with the federal government. We anticipate that it will be approved this fall, and that is to be able to provide Maine Care coverage to youth and adults who are in Maine correctional facilities 60 days prior to release. So this is a huge opportunity to help those individuals continue to receive the care, receive new services that they haven't been able to access, and to prevent recidivism. And we will be implementing, our hope is to implement this program in 2028. Also, we, as part of that same application, are looking to be able to cover traditional healing services through Maine Care as well. So these services have sustained Indigenous communities for generations. They're important supports for substance use disorder, and we're working closely with the Wabanaki Nations to implement this, and our target is for 2027. We face real challenges in the state and the country right now when it comes to maintaining Medicaid coverage, and especially for individuals with substance use disorder, where we know that for all of us, staying on top of paperwork is an issue, and especially when you're working towards recovery, that can even more so be the case. So there are real challenges, but we're also achieving meaningful progress, and we really need your partnership to continue to move forward on both fronts. Thank you very much.
Okay. Thank you, Michelle. I want to call on the stage our Commissioner of Health and Human Services, Sarah Gagne-Holmes, who's going to introduce the governor. I also want to thank our signers here. You've seen them all day. They're the hardest working people in the building. Commissioner Gagne-Holmes, I love her to death.
Thanks, Gordon. I can see what all the other speakers said when they look out on this room. It is, wow. Nice to see you all here today. I am Sarah Gagne-Holmes, Commissioner of Maine's Department of Health and Human Services, and I have the distinct honor of introducing our next speaker, Governor Janet T. Mills. Before I do, I want to take a moment to recognize what a meaningful and powerful morning this has been. We have heard from leaders, providers, partners, and people with lived experience, each bringing a different perspective on prevention, treatment, harm reduction, and recovery support. Together, they have reflected the spirit of this year's summit theme, building hope, honoring progress, and inspiring change. That theme is especially fitting as we prepare to hear from Governor Mills. From the beginning of her administration, Governor Mills made clear that Maine's opioid epidemic demanded urgent, coordinated, and compassionate action. She understood that saving lives would require more than one program or one policy. It would require a sustained statewide response built on prevention, treatment, recovery, harm reduction, and connection to care. Much of the progress we recognize today has been shaped by the governor's leadership. One example that deserves special recognition, the incredible impact of Maine Care expansion. Governor Mills championed Maine Care expansion from day one and made it a reality, dramatically increasing access to healthcare to people across the state. That decision created a foundation for so much of the progress we recognize today, expanding access to treatment, supporting recovery, connecting people to services earlier, and helping ensure that more Maine people can get care when and where they need it. That foundation has helped Maine build a broader and more connected response. With the governor's commitment, Gordon Smith's steady leadership, and the coordinated efforts of multiple DHHS offices, and the partnership of so many people in this room, Maine has strengthened prevention, expanded naloxone distribution, increased access to treatment and recovery supports, advanced outreach through options, and supported programs that meet people where they are. Maine's response reflects the governor's understanding that substance use disorder is not solved by a single intervention, but by a system that keeps reaching people with care, dignity, and hope. The progress we honor today did not happen by chance. It reflects clear leadership, sustained commitment, and a belief that every life is worth fighting for. As we look ahead, the work before us remains as important as ever. Because of the governor's leadership, Maine is better prepared to carry this work forward with continued urgency, compassion, and shared purpose. Please join me in welcoming Governor Janet Mills.
Thank you, Commissioner. Thank you so much, and thank you for your service to the people of Maine, which has been remarkable, faithful, persistent. Hey, how are you? A lot of familiar faces here. This is good. This past June, on a hot summer day, a woman named Tara was watering her flowers on the grounds of a hotel in Kennebunkport as she talked about the found community that has given her and 14 other people a true lifeline. She is the beneficiary of Raising People Up, a program at Nonantum Resort, started 5 years ago. Nonantum has offered meaningful work to people like Tara who are in recovery and who are recently released from incarceration. But a paycheck is not the most important part. The important thing is the connection and the culture of community that keeps Tara on track. As she puts it, quote, "It's just the constant positivity. And how can you not stay in a good mood and stay happy?" she said. It's often said that health is more than just the absence of pain. Well, happiness, too, depends on more than the absence of sadness. It is human connections that build hope, that honor progress, and that inspire change in each of us to reach our full potential. 8 years ago, our connections with each other were undermined by the widespread belief that people who were addicted to substances were just somebody else's responsibility. As Attorney General, I witnessed firsthand Maine's slide into addiction. For years, we watched as more people fell into the allure of drugs and substances. We watched as members of law enforcement faced a growing public health crisis, with handcuffs being their only tool. And we watched as state government agencies operated in silos, seemingly incapable of confronting the crisis or even talking with each other about it. All the while, Maine people in every neighborhood, in every community, who were struggling with substance use bore the stigma and the blame, even as they were losing their lives to it. In the 5 years preceding 2019, more than 1,600 people in Maine died from drug overdose. We were losing one person a day. About 8% of all babies in Maine were born substance exposed, 3 a day. The life-saving drug naloxone was not readily available. There were few treatment beds in Maine, and when somebody was ready to get into recovery, even fewer treatment options existed because you didn't have health insurance. We began to see that the opioid epidemic was not a white-collar or a blue-collar problem. It was not a rural problem or an urban problem or a suburban problem. It knew no boundaries, no zip codes, no tax status. It knew no age limits. So when I became governor, I knew that what Maine had been doing for so many years just wasn't working. I knew we needed to break down the silos of state government and set aside the stigma, speak out about every aspect of this opioid epidemic. I promised that we would put the full force of my administration behind the families who lost loved ones, the businesses who lost employees, the communities that had been diminished by this public health crisis. So my very first executive order, signed my first day in office, fulfilled the will of the people and expanded Maine Care to more than 90,000 people. And today, about 40,000 people receive treatment for substance use disorder through Maine Care. And thank you, Michelle Probert, for your insights and information about the hope of Maine Care. Many of these people and thousands others now may lose their health insurance because of the new rules, new restrictions, and paperwork required by H.R. 1, which Congress enacted last summer, as you know, along party lines. By the way, while Maine is poised to receive $190 million through the new federal Rural Health Transformation Program, and why we will use some of those funds to hire recovery coaches in more hospitals, that money still pales in comparison to the billions in healthcare funds Maine is set to lose over the next 10 years. Let's not forget that. Expanding health insurance was a critical first step to confronting the opioid crisis. Then, right after issuing Executive Order 1, I appointed Gordon Smith as Maine's Director of Opioid Response to be my eyes and ears on the ground, talking with people all over the state. Where's Gordon? Where'd he go? Talking with people all over the state to figure out how we could save lives, renew our economy, and show that we care and rebuild communities. Thank you, Gordon. I also want to acknowledge the work of the woman who led my Office of Policy, Innovation in the Future, that included, supervised, to the extent it was possible, supervised Gordon and the opioid response team for 6.5 years. Former Speaker of the House, Hannah Pingree, I think she's here somewhere. And her successor, Sarah Curran. Thank you, Hannah, for your continuing leadership in this area. My second executive order encapsulated 4 basic strategies with specific action steps. The first, establishing a prevention and recovery cabinet made up of commissioners from 14 different government agencies, the Attorney General's office, and the judicial branch. Then we outlined steps to prevent overdoses and deaths, including making naloxone widely available statewide. I'm proud to say, since early 2019, we have distributed more than 870,000 doses of naloxone, saving thousands of lives. Some days I think back about how my predecessor treated this issue. How he used to say so dismissively, naloxone doesn't save lives, it just extends lives. It doesn't save lives. As he was saying this, I was driving around the state as Attorney General handing out naloxone, bought with pharmaceutical settlement funds, to every police department that would take it. We then outlined steps to expand effective treatment and recovery efforts, including medication-assisted treatment in the criminal justice system. We trained 250 recovery coaches, and we funded recovery coaches in 10 emergency departments. Today, Today, nearly 1,000 people in our prisons and 1,100 people in the jails are getting medication they need to begin the path of recovery, not relapse, not reoffend. As a result, our recidivism rate is down statewide and our communities are safer. People are more whole, they're finding productive lives. We've now trained more than 4,000 people as recovery coaches. Yeah. We've funded coaches in 10 emergency departments and more to go. And we've increased the number of certified recovery residences from 11 to 119. We've created a recovery coaching for youth program for schools in Hancock and Washington counties, creating those peer-to-peer connections that give a young person the sense of community and care, the hope to face the future that they need. We also established the Cumberland County Crisis Receiving Center, you know as the Living Room, to provide walk-in services for anyone with a mental health or substance use crisis. And since that center opened, more than 3,300 people have gotten help there. Pretty successful. Crisis receiving centers work, which is why we're opening more of them in Androscoggin and Penobscot counties. We've expanded behavioral health clinics, which offer mental health and substance use treatment to anyone, regardless of ability to pay, insurance, or where they live. And today, 21 clinics are helping more than 13,000 people all across the state of Maine. We've added 68 residential treatment beds since I've taken office, including 20 detox beds. And statewide, there are more than 600 treatment beds, and new ones are opening up every day. I think there's this myth out there that there aren't any treatment beds. Well, they are there. The VA has just opened a new treatment facility for veterans at Togus. And something called New Leash on Life Recovery and Rescue has opened up for women in recovery who want to keep their dogs with them. I think that's important. Executive Order number 2 also directed Gordon Smith to create targeted prevention programs in schools, workplace, and community organizations to prevent opioid abuse. So now, for instance, at Wyndham Middle School, 7th graders are learning about opioids from law enforcement and UNE pharmacy students and from people in recovery. They created 2 newspapers and they dated them 2055. One is focused on a future where their generation has solved the crisis, and another one, a darker one, where they did not. They're learning that they have a choice and a chance to change things in the future. We're offering educational programs as an alternative to punishment, bringing students, parents, and school officials together to intervene early when a child shows up with substance abuse disorder. We expanded school-based health centers that provide critical health screenings for thousands of students. We've held statewide trainings like the Maine Youth Action Network, the Youth Leadership Conference, which taught more than 400 people how to create positive change in their communities and in their lives. We supported 94 schools in 14 counties as they implemented the very successful BAR program to look at risky behaviors and address them one-on-one. And we worked with the Maine Recovery Action Project to develop a youth naloxone curriculum to train young people on the signs of overdose and how to administer naloxone. Our Options program has placed mobile response teams in each county to work with law enforcement and connect people directly to recovery services and treatment. You remember Operation Hope, and this is an extension of that, how the police departments threw their full weight behind these recovery efforts and getting people into help but not just into jail. So, 2 years ago, one of our Options liaisons in Aroostook County, Justin Martin, helped a family get medication and treatment for substance use disorder. The couple said, quote, "We've been through all of it and get to enjoy everyday things now because we got into recovery and continue every day. We've been there now for our babies since day one because we chose recovery and happiness," end quote. We've created treatmentconnection.com, a one-stop shop for people seeking treatment. And so they can get to know what behavioral health services are available in real time among more than 500 providers on the list. Since that went live in 2025, Treatment Connection has been used 8,000 times. So critical. And trained crisis support specialists answered more than 150,000 calls and texts through the 988 crisis hotline over the past year. 150,000. Including more than 1,100 directly related to substance use. We've taken many other steps as the approach to addiction has evolved. That includes the Home for Good program, providing cost-effective, stable housing along with wraparound services to address homelessness and substance use with proven success. The first 8 Home for Good developments will serve 230 people with medical and behavioral health services on site. We're also increasing good-paying jobs for people in recovery. You know, rewarding businesses who understand the unique experiences and skills of people in recovery is important. So we created the Recovery Friendly Workplaces designation, a certification now held by 86 businesses who employ nearly 25,000 people statewide. One of the earliest of those recovery-friendly workplaces was the Nonantum Resort I mentioned before, where the woman I spoke about earlier, Tara, works and where she has found a culture of community. My administration is doing what it can in a responsible manner to stop deadly drugs from reaching Maine, to prevent substance use disorder in the first place, to treat it when we can't prevent it, to set people on a lifelong path to recovery, and above all else, to save lives and allow people to achieve their full potential in a caring and welcoming state. And our work is paying off. From January to June of this year, fatal overdoses decreased by nearly 9% in Maine. Thank God. This is the 4th consecutive year of declining overdose deaths. In 2024, we recorded the lowest number of substance-exposed infants since tracking began in 2012. Still, the threat looms. People are losing hope. Some people are dying. And we have to acknowledge that every overdose death is a tragic and, I believe, preventable loss of a valued life. Over the past 7.5 years, these summits have focused on turning the tide after an epidemic of deadly overdoses, on ending the stigma surrounding addiction, and on persevering through the isolation and loneliness of a worldwide pandemic, on finding creative solutions to entrenched problems. In our most difficult moments, we turned despair into resolve, solitude into strength, complacency into courage. Because of you, your dedication, your unshakable faith in the future and in the worth of every human being, the future is looking better. And to people across the state of Maine, including the 1,000 people gathered here today and those watching at home live stream, I ask all of you to recommit to preventing addiction in the first place, to supporting people as they start, stumble, or resume their recovery, and to reinforcing this important relationship, the relationships you're building here and in communities across Maine. For it is those relationships that save lives. While you won't see me on this platform next year, I will say that one of the best parts of this job has been working with folks like you and people like Courtney Gary Allen. Where is she? People who helped us see the reality of reentry and recovery. We don't always agree on solutions, but we know we have to keep talking, and that's how we make progress. I will miss working with legislators like Holly Stover, who answers those calls in the middle of the night and gets people help one-on-one relationship building. People like Noah Nesson and Eric Steele, the 1,000 Lives program, doctors who put their whole hearts behind saving people's lives and saving people from lifelong addiction. And from these gatherings, I have felt your commitment to eliminating addiction, not giving up during the most trying of times, widening our state's understanding of recovery, and fighting for change and a deeper sense of community, always being present for others. And then when I get letters from a parent, for instance, whose child has come home again, healed and hopeful, on the road to recovery, well, that makes this difficult job worthwhile. So don't ever give up. Make sure that the next person who occupies the Blaine House appreciates all that we've been working on together for so long. Keep up the good work, and thank you from the bottom of my heart. Thank you. Thank you all. You're the team that makes it worthwhile. Thank you. Now look, one of my most treasured moments as governor is being able to recognize individuals who've made meaningful contributions to our opioid response efforts. Well, I'm really sorry we lost Robbie Moulton of Scarborough. He's no longer with us. I do want to welcome some other folks who've received awards in the past for their work on opioid prevention and treatment. So I'm going to ask Shelley and David Jankowski, Scott Party, Peter Brune, Marcella Sorg, Leslie Clark, and Danielle Farino, all past award winners. Please join me on stage. Those are the two. Oh, it's good to see you all. And now to receive this year's awards, I want to invite Dr. Ronald Springill and Pat Kimball to please join me. Where is she?
She's
on her way.
You did leave some good news.
How are you?
Good.
Good to see you, my friend.
Congratulations.
I'll start by saying, since January 2019, there's been no stronger, steadier champion of Maine's opioid response than Dr. Ronald Springill of Scarborough. A retired physician, he started as an unpaid volunteer coordinator and ultimately became the executive director of the Maine Association of Recovery Residences, a state affiliate of the National Alliance of Recovery Residences. You know, 8 years ago, Maine had no certified recovery residences. Today, we have 119 such homes, including at least one in each county, at least one. This growth is remarkable, and it's a remarkable achievement. It's due in no small part to his leadership and unwavering support of people in recovery. In long-term recovery himself, he serves as a beacon to people who are working hard every day to maintain a life of sobriety and recovery. In recognition of this extraordinary service to Maine and to our residents, it is my pleasure to award the first of our 2026 recognition awards to Dr. Ronald Springill of Scarborough. Something? It's up to you.
Thank you, Governor Mills. This is an award that belongs to many. Many of you are sitting here, especially my staff over on the left. But none of this would be possible without her leadership and the brilliant insight to appoint Gordon Smith as the Director of Opioid Response, and all of the work that's done by options liaisons, the harm reduction people, MERAP, there's so many, but it started with an election, and it had consequences. In this case, consequences were thousands of people's lives were changed and saved.
I'm proud to present the second recognition award this year to my friend Pat Kimball of Herman. Yeah, everybody knows her. In 2016, she allegedly retired after 15 years of leading Wellspring, Maine, a Bangor-based nonprofit with a long history of providing services to support people in recovery. But as Pat told a news outlet at the time of her alleged retirement, quote, "I could never just walk away from this work. I will just use another path." And that she has done. That path included being appointed by Attorney General Fry to the Maine Recovery Council, and then being elected chair of the council the first 4 years of its existence. As the chair, she has steadfastly led the council as it took responsibility for allocating 1/2 of the state's opioid settlement funds. In recognition of her lifetime of work advocating for those struggling with substance use disorder and their families, I proudly present this award to Pat Kimball of Herman.
I am truly overwhelmed.
I'm going to try to say something. First of all, to get this award from one of my heroes, who was absolutely, when we were at our worst, came forward and put what needed to happen to put the opiate crisis in a place of importance and a priority, and she saved lives, along with her cohort, Gordon. I cannot tell you, I'm overwhelmed. The other thing I want to tell you, the significance of today. Today, in 1967, my dad walked into his first AA meeting. This is my dad's anniversary. And my dad would be so proud. He not only walked into that meeting and never looked back and went into recovery, but our family also has had that same opportunity. All of you in the audience that I have worked with over the years, I love you all. I love this work. It's never ending. I do retire, but again, there's always a path. But I cannot thank you all enough for giving me the privilege of doing this work. Thank you.
We love you, Pat. So familiar. Well, on behalf of the 1.4 million people of the state of Maine, I want to express my deep gratitude to these people, all these people on the stage. Now I'll turn things over to our Director of Opioid Response, your esteemed MC, Gordon Smith. But before I do that, I just have one little thing for you, Gordon. Somewhere. Thank you. We talk a lot about executive orders, and they're just pieces of paper, of course. Executive orders have only the meaning that the words describe and only the value of the people who implement them and carry them out. But Executive Order 2 has been special to me, to my staff, to my cabinet, and to the state of Maine. And so I want to present Gordon, who's responsible for all this work, with a limited edition signed copy of Executive Order 2 with a little inscription for you. Thank you, my friend. Now you can take over.